Hello, hello. Welcome back. So, right now we have about 65 people joining on Zoom, and right now we have our expert with us. Welcome, Dr. Kalpana Kanel and Dr. Samuel Bradley. Yay! Yeah. So we will start this afternoon session with the local. Yeah. So we will start this afternoon session with Dr. Naphapong Pongnapang about all the summary on whatever we talked in this morning about the DRL, DIR, and the next step that we are going to do. And after that, we're going to have Dr. Kalpana Kanel and Dr. Samuel Bradley talking to us about what can we do to like optimization and things. Let me look at the schedule. It's like we're going to talk about the objective of the mission, computer tomography, dose metric, standardized CT protocol, and standardize the DIR data collections. So let me give some like introduction to our speaker. So Dr. Kalpana Kanel, she is a professor at University of Washington at Washington, Washington, Seattle. She is a chief of the medical physics. And if you remember, she's like I would say like a godmother or like a mother of the DIR or something that helped the ACR, American College of Radiology, establish the national DRL, DIR, and everything. So today we're gonna learn from the expert, right? And then the next person is Dr. Samuel Bradley, old friends. He has been here with us since 2017, come back on 2018 or 19, and then like did the expert mission for 3 months over the nighttime from like 9 p.m. to midnight for 3 months. And that you can watch the online session, those things on the YouTube and Facebook Live. And this time he come back again to like complete the mission that we first started in 2017. So next step, Dr. Napapong, I will give you a stage to give like the summary on everything that we talked this morning and give some summary to the expert. That one.
All right, I'm gonna use this mic. And good afternoon for the friends from across the region. I believe that we have some participants from Singapore and also Korea and maybe other country because we did really advertise about this event. So feel free to register and tell your friend to register for this special event. What I'm gonna talk about, I thinkเมื่อเช้าใส่ไปแล้ว Oh, okay. I think the staff just put my PowerPoint on the folder. So I will give a little brief on overview of Thailand Dose Index Registry project. And I'm Napapong Pongnapang. I'm the coordinator for this project together with the staff here, which I will introduce to you later. So what I'm going to talk about is about radiation safety and quality standards in Thailand. What have we done? What are we doing? And what we will do in the future? And why we focus on the CT or computed tomography at the moment, and a little bit on the basic safety standard, which is the IAEA, the International Atomic Energy Agency standard on radiation protection. And at last, I will talk about Thailand DIR, the update. Just give you a brief introduction about Kingdom of Thailand. Kingdom of Thailand is situated in the heart of Southeast Asia mainland. We have the area probably the size of France, about 500,000 square kilometer, with pretty much the same population, about 69 million people living in Thailand. And the first independent Siamese kingdom or Thai kingdom was established back in 12th century. So we are quite young in age compared to other country in this region. So Thailand is about 800 years old, and Thailand now, our economy is at the level of upper middle income, categorized by the World Health by the World Bank, and just this year, the Human Development Index of Thailand just moved up to very high Human Index Development Index, which is more than HDI more than 8.00. That's mean it's quite equal to the developed countries already for the Human Development Index for Thailand. For radiology in Thailand, the first X-ray equipment was brought in the kingdom back in 1898 by Professor Hans Adamson. Professor Adamson was the royal court physician, so he brought in X-ray machine to use with the royal court people like the king, queens, and prince and princess. And Thailand radiology education and training started back in 1928, so it's like more than 90 years already, with Professor Pin Myung Man, who is the first pioneer radiologist trained from Harvard University in the US. So he came back and established the radiology training in Thailand. So he is the father of radiology of this country. And at present, we have about 2,000 radiologists, 250 medical physicists who mainly work in radiation oncology. For diagnostic physicists, we may have quite a few, maybe less than 20, maybe 10, or maybe less than that, depending on how would you define the term of diagnostic physicist. And we have about 6,000 radiological technologists working in the healthcare system. For radiation safety and quality management in radiology in Thailand, we have the law. We are the UN member state, so at least we need to have a law equal to the basic safety standard by the IAEA. So we have the Nuclear Power Safety Act, which was updated in 2016. And for profession, radiologists and technologists have the will practice under the control of the relevant professional law. They have the radiologists practice under the medical council, and the technologists practice under the Radiological Technologists Board of Thailand. And recently, a medical physicist license was effective by 2021, but the first batch, 17 physicists, just got past the examination to get licensed 2 months ago. I was among them. That means I am not young anymore. We are like grandfather, grandmother of the medical physicists here in Thailand. And updated regulations stipulated that radiation emitting machine in diagnostic radiology and dentistry are required to be registered at the Ministry of Public Health. So before you can be those machines can be registered, those machine needs to be tested by the physicist. All right. And for quality management and clinical audit, we established the Quadro. It's from IAEA, Quality Assurance Audit for Diagnostic Radiology Improvement and Learning. This is from the IAEA. We have the project with the IAEA to establish this clinical audit. And one hospital, which is this hospital, King Chulalongkorn Memorial Hospital, already audited. And two more hospitals are on the way along. Since the COVID time, we stopped for almost 3 years. So we will start early next year at Mahidol University Ramatipudi Hospital, and also Chiang Mai Hospital in the north. But for radiation oncology and nuclear medicine, they are very mature already. We transformed the IAEA version to local version already. That means in radiation oncology and nuclear medicine, those facilities will be audited by domestic body, which is the professional society. This clinical audit is pretty much the independent assessment of how actual clinical practice compare with the good practice, and this is pretty much peer review. So when IEA send the expert to audit, they will send one radiologist, one physicist, and one technologist to look at how well you perform, compare against the standard with among the quality of all elements, including staff, equipment, procedures, patient protection and safety, overall performance of the facility, and also interaction with external service provider. And why CT? I like this photo because this is the ACR CT Phantom. Now we have 3 in the country. not to wonder, because normally when we test the city we use CAT fan still. So this is like kind of progress that we kind of introduced the ACR version of the Phantom. And I'm not gonna talk much about this, but for optimization of protection and safety, this is clearly said in the basic safety standard. So the component listed in the BSS about optimization include the design consideration, operational consideration, calibration, patient dosimetry, and DRL, and also QA and those constraints. So the project that we have been doing comply with this standard of optimization of protection that include the diagnostic reference level. And step further, what we will do is the dose index registry start with the CT like other countries. For diagnostic reference level, we follow the ICRP standard publication 135. This is to basically we did a lot of training, and we have a lot of assistance from IEA. We have Sam flew in, and also other experts to help us with this project. So we already published the DRLs for all modalities is done. But since we need to update likely every 5 years, so first modality what we did for DRL was the plain radiography, and now the technology just shifted to flat panel detector. So the dose matrix that appropriate for the flat panel detector will be more like CAP, the Kerma array product. In the old days with the CR and film screen, we use intrasurface air Kerma, which is suitable for that technology. But from this year, we'll start to collect the data for DRL in plain radiography using the DAB or the CAP. And this is the publication by the Ministry of Public Health about DRLs. So next phase along our plan is to establish National Dose Index Registry. So basically, this is the data warehouse that have the information from the feeding sites. And the purpose of this project include we need to provide national data to the regional facilities, and data can be used to develop the DRLs with maybe a different approach from what we have done so far, which is the data collection from different hospital using standard size population, which is big different from the others. We use 60 kilograms plus 60 plus 15 kilograms, and Europe they use like 70. And we will provide benchmarking for facility to improve patient care, which is the optimization. The plan that we proposed to the agency, the first phase, we got the budget from the agency about 300,000 euros, and the project is entirely supported by the AEA. And here are the dose metrics that we will collect. Effective dose is not the individual dose though, but we also provide the data back to the unscare. So effective dose will be one of the parameters that we will provide. If you look at the health system in Thailand, we have different type of hospital. The first type is the government tertiary care referral centers. We have 33 of them across the country with capacity of about 24,000 beds. And smaller size, mostly provincial hospital. We have 78 province now, roughly. I can't follow up how many provinces that we have. It's more like district. It's not like province in other big country. But we have a general hospital, about 83 of them with 25,000 beds. And we have a small community like from like district. So people can get access to basic Medicare. We have 780 of these community hospitals, and most of them has X-ray facility, but may not CT. These include 38,000 beds. Another hospital under the Ministry of Health, MOH, we have 59 hospitals and 12,000 beds. And we have government hospital outside the Ministry of Health, which means those university hospital that belong to the military, the police, or Red Cross. Like this King Chulalongkorn Memorial Hospital belong to the Thai Red Cross. Okay, and we have the private hospital. In Thailand, it's quite unique in Asia because the private sectors, they take care quite a portion of the people. There are 347 hospitals belong to the private sector, which have about 35,000 beds, right? And for the healthcare provider in Thailand, we have four schemes. The first one is the government civil servants insurance. So this is one of the best because you don't have to pay anything, and they pay for your parents, your wife, and your kids when they are younger than 18. So this is very good health insurance that we can have. And the next is the social security. It's more like for people who work for the private company. And for those who don't have the first two, we have universal health care for the rest. So these are like basic health care that people can get access to without pay. You co-pay only $1 for like heart surgery. That's all. But the line may be long, but you can get to access to that, and the CT scan, MRI scan also included in this scheme. And the fourth one is private insurance through the health insurance providers that you can buy for yourself. Here are key players in this project. The first one is the counterpart of the IEA, our NRC, we call Office of Atom for Peace, and Ministry of Public Health, of course, and also the professional organization. We have the Royal College of Radiologists, which is our ACR, and we have our RSNA, the Radiological Society of Thailand, and we have our AAPM, the Thai Medical Physics Society, and we have our ASRT, the Thai Society of Radiological Technologists. We have the subcommittee appointed by the minister here for patient dose tracking and DRL. Dr. Palutai here. She is the chair of this subcommittee ad hoc. And members include key persons from professional organization that I mentioned before. And we also responsible for this Thai DIR project. For this project, it is solely based on US version of the ACR DIR, and Thailand is the second country in Asia after Japan to run a similar project. But Japan, they already established extensive network of the national dose index registry already, and the aim are to establish national diagnostic reference level and to promote safety and quality of practice related to CT. And the main benefit for this project is to promote the utilization of the DIR with aim for dose optimization. That's why we have the IEA mission here for this week. First, we propose with the budget of 300,000 euros. We proposed for 13 sites, but the money was not enough. So we end up having 9 sites with one central data clearing center at our NRC. And we plan to hook the existing sites also, but it was not happening at that time because of the COVID. So basically, we have main data center with 9 feeding sites at first as the initial phase, but currently we have more than we have above 1,000 CT scanners across the country, quite a number. So basically, Thai population can easily get access to the CT scan, like within 20 minutes drive, you get the 2 CT scanner anywhere in this country. Unless you live in a jungle, of course, but not many of us there. So what we do, we follow the standardized CT protocol by the LATLAX. Sam came to give us lecture about this before, so we just adopt that. And what have we done so far? We did a lot of numbers of IA missions to train local professions on patient dose optimization and DRLs, and we run a lot of seminars on standardization of Thailand CT dose protocol because our scanning protocol may not be the same like what you do. So we have series of meeting among the profession across the country, and then we come up with the consensus on what we want to do. And based on ACR, DIR, and RSNA LATLEX, we have total 10 protocols, which is based on ACR, DIR. And we have 4 additional protocol, which is based on Thailand specific healthcare reimbursement protocol. So as I mentioned, there are 14 agreed protocol, and we run the code. Like if the ACRDR code, we run RPID code, and for additional protocol, we run THBD code. Why is that? When you're grouping the protocol from different hospital, they may name it differently. So whatever protocol that fall into the category, so we will name it uh, like this. RPID 22, which is brain non-contrast. So whatever the name of the protocol, we leave it that way, but we put the code. So when we sort the protocol, it will come in. All right. So these are 14 protocol: brain, neck, chest. Chest we have 3: chest non-contrast, chest contrast, and chest contrast and non-contrast. And we have upper abdomen, whole abdomen. The additional 4 are those chest plus upper abdomen and chest plus whole abdomen. This is the way we scan. So this item we use for reimbursement. So this is, we need the code for this. So these, the last 4 we mainly use for internal comparison. First, it's very hard to get the volunteer. Even we bought the dose management system for them. They seem quite hesitant, like, oh, will the data from the patient leak out or something? So we have to convince them. Thank to Dr. Banner that you talked to her radiologist colleague. We need radiologists to be on board because they kind of control the thing. And we have 9 hospitals across the country to join this project. So this project is like this cyclic data driven, like you is that already been established, like facilities submit the data, then we have quarterly report back to them. I will show you what we do, which is based on the ACRDAR, and then we develop the improvement plan. For this stage, we have collaboration among the professional societies, organization like the College of Radiologists, the different society, professional societies. So if they have problem, we will step in to help them. So here are what the data look like. This is the DLP from 14 protocols, and this was from the first 3 months, first quarter. So we have number of exams. So the first 3 months, the installation was completed, but the protocol grouping maybe in some hospitals still have some problems. So we believe that the second, third, and fourth quarter we will do better in this. And we have the data like normal that we should have, like minimum, maximum, mean, SD, P50, P75, and P90. And this is the CTI volume data for 14 protocols. What the hospital will get back from us is the comparison, the data. They will not see others' hospital data. They will see the national data, and they compare with our national data. And we pick up some of the international and local published DRL for them to compare. We have Thailand from Ministry of Health, and Thailand also have another project run by the group of university hospitals. So the main differences between these two is that the project run by university hospital, their CT scanners are newer, more like 64 slides up, so it's new. So the dose may be different a little bit, but for the public health, they do data collection, so they go around the country, and we still have a lot of old machines. Well, we may not have the single slice anymore, but we still have 4 and 16 slices. And we draft the letters in Thai back to like executive summary so that the hospital director can read only 1 page. So we will not get him bored or something like, okay, this is the data, but the detail we send to the radiology department so people can take a look. The next phase with the budget that we request, we mainly distribute the dose management system for free to the government hospital where they may have limited budget. But at the moment, we have more than 50 hospitals having the DMS, mainly university hospital and a private hospital. In the private sector, most of the time, most of Thailand hospital, we do JC, Joint Commission, but international version, the JCI. The difference between JC and JCI is that JCI version follow JC by like one cycle. But surprisingly, JC already stipulated that you need to buy the software, but JCI within the last two cycles they have not enforced yet. But they just say it clearly that you need to know the dose that you expose to the patient. So a lot of private hospital they don't have in-house physicists. So what they do, they just pay money to buy the software. So then when they get accredited or audited, they don't have to worry. Just this is the dose the patient get, and that's done. But the thing is, what we need is to maximize the benefit of this dose management system. We don't want them to just invest the money, just that they get accredited. They need to use it. So we will encourage them. But the first phase, our data center is not that big in terms of capacity. So we plan to expand the capacity to handle about 2 million exams per year so that it will be able to handle these data if those hospitals agree to enroll in this project. So these 250,000 euros, which is same as dollars now, we will use in two things. First is we expand the capacity of the central data center, and also expand to 8 centers, 8 feeding sites for the government sector. So at the end, I talked to some vendors. They are now actively promoting to sell this dose management software. I think within the 2 to 3 years, we will have much more for different type of hospital. So we still have a challenge because those registers very new to Thailand, and let alone patient dose monitoring and audit, and encouraging the facility to participate is based on willingness. We don't have the law or accreditation requirement. We have the national scheme for hospital accreditation. We have the advanced version we call advanced hospital accreditation or advanced HA. With the involvement of the radiological society, we managed to put some clause in there that we need to have the dose matrix from the radiology exam, but at the moment we have not put this because it's too advanced for the country. But maybe in the near future we will start to put in these requirements so that at least if we have the accreditation requirement, people will use the DMS. All right, so that's all for me. Any questions so far?
We don't have any questions from the audience online, but any questions from the on-site audience? Or any comments from the expert?
I think this is very impressive, actually, what your country has done in establishing, and I'm just amazed that you only have 14 protocols because if you look at my hospital, we have tons of protocols, right? So I think it's good that you're keeping your list, just what you need, right? And I think if you keep that simple, this is so much easier to do than the 250 protocols that I have at my hospital, right? We have tons of protocols and it becomes a real nightmare to manage. So I think this is a great, very impressive start to what you're doing. And I think you're already ahead of a lot of other Asian countries. So congratulations on a great, project that you guys are doing here. And we are happy to help however we can.
All right, thank you. Actually, some hospital, like one of my university hospital, they have 600 protocols. But just for comparison's sake, we agree that we just use this as first stage. But grouping the protocol is big headache. And other countries want to learn this from us too. I got a lot of questions raised from different countries, like how did we do it? So we are also willing to help them. But we also need to learn a lot from you about this too during this trip. Okay, thank you.
Thank you so much, Dr. Napaporn. So the next sessions is about the objective of the mission, and this is that the thing that you want to discuss with the local need, or
Yeah, we're going to talk about objectives.
objective? Okay, introduction. Okay, by Dr. Samuel Bradley. Yep.
Well, good afternoon for those here on site. It's great to have you. And then for those of you in the virtual world. So today I want to start off by doing a little bit of an overview and summary of what we intend to talk about over the course of the next 4 days, including today. There we go. And so let's start by painting a picture. Why do we want to set up dose reference levels, DRLs? But when we ask that question, we have to remember that in imaging for radiology, everything always has some kind of link back to dose. So the quality of the radiation, the image that we create, be it an X-ray, fluoroscopy, and of course this week we're going to focus on CT, there is a component that requires us to figure out how much dose we use. And one of those things is, as you can see here, it's just a very simple mathematical relationship. But the idea here is when you add a little bit of radiation, it cleans up the noise, but they're not one-to-one. They're not linear. And so when you're going from left to right, going from a very low exposure event to a higher exposure event, there becomes a dose penalty as you keep going up and up. The images on the right, of course, have very little image noise, so image quality-wise, they're very pleasing to the eye, but they require several factors or several orders of magnitude more in radiation to get there. So what we need to do is we need to improve our imaging to get up good image quality, and we need to do that with as low a radiation dose as possible to maintain safety. So I want to talk about risk for a few slides. I just said that we use radiation to create the image, and we use radiation to create good quality images. So what level of radiation are we using? And should we be concerned about it? Well, what are the things we do know about radiation? We know that, for example, when it comes to risk to the tissue, that there is a threshold. And so when we image at a value that's below this threshold, we know there will not be an effect. What are effects that we are familiar with? Of course, we understand that we can have hair loss, we can have epilation, or we can have various different forms of tissue damage to the skin. Reddening, which would be basic here, or maybe even more like desquamation, where we actually get ulceration. We know that if the radiation dose is below a threshold, this doesn't occur. And so we don't need to worry about that. Beyond that threshold, as we increase the radiation dose, the effect becomes more severe. Now we're going to spend this week talking about CT. These effects can happen in CT. So at the higher end of exposures, we can see hair loss and skin reddening. So tissue effects have been very well documented in the scientific literature. What about cancer? What about the stochastic effect? And this is something that's very hard to understand because, I'll explain in a few slides, but the amount of radiation that we give is not directly linked to the severity of the disease in this case. Now the amount of radiation we give for the imaging is related to the probability that we will get cancer. So we look at this, for example, here's a graph on the right-hand side, and we understand that for the pediatric population, they have about a 10 to 15% greater risk for lifetime cancer induction, or to get cancer at some point in their life, when they are exposed to radiation at a younger age. And as we get older and older, basically by the time we get to become adults, usually about 60 years and older, the risk goes to basically nothing. And that's just because most people will die before their cancer would actually be able to grow and be the reason they die. So radiation risk for our adult population or our elderly population is actually very low. And so when we talk about radiation risk, I come from actually a pediatric hospital. The types of patients we deal with are almost always 18 years and younger, although we do have a smaller, younger adult population. We're very sensitive to the amount of radiation we use in our imaging because of this one thing. Kids are more sensitive, they're younger, so they have longer to live, and their bodies are still growing. They have a lot of cellular growth, and they're constantly aging up, and so they have a little bit more risk to cancer effects. All right, so what we do know about radiation largely comes from the studies that have followed the population that survived Hiroshima and Nagasaki atomic weapons used in World War II. So the majority of what we understand comes from epidemiological studies. And we know that at a certain level of exposure, typically shown at about or greater than 100 millisievert, so it's a whole body exposure to a population, we know that there is a linear increase in probability of cancer. We understand this region right here very well. It's been studied. We've obviously been following the population that were present during the atomic weapons. And then we actually studied, and not we, but the UN and everyone else, they have studied the populations that were from Japan, but they weren't present. So they had a control group and then an exposed group. And that's why we know that the radiation at this level has a greater chance or probability to invoke cancer. So where are we? We're talking imaging. Well, there's various different modalities, and they all have different levels of radiation. Specifically, we're going to talk about CT this week. And so we're going to be in the realm for abdomen, about 5 to 10 millisieverts, and chest, usually 1 to 3 millisieverts, depending on the age of your equipment and how well those pieces of equipment are optimized. And irrespective of the fact that it could be 1 to 5 or 5 to 10, those numbers are all an order of magnitude lower than this known area of risk from cancer induction. So when you look at things, we're all the way down here for imaging. Diagnostic imaging really does use a very little amount of radiation. So the overall burden of cancer in a population obviously increases with age. So though some pediatric patients could be born with cancer, or some could have cancer occur to them while they're younger, the majority of cancer, of course, occurs in our elderly population. And so the thing that I want to point out here is this idea of latency. And so we talked about how kids are more, or pediatric patients can be more sensitive to radiation. But an event, an exposure event, a radiological event, say they go in for a CT scan or an X-ray, there's going to be a certain period of time called latency period between that exposure event and the time that the disease, in this case cancer, would manifest. And because of this latency period, this time between exposure and induction, it's very hard to associate risk with radiation. And so we understand cancer happens later in life, but does cancer happen later in life due to radiation induction? And that has been the most difficult problem to overcome when we try to talk about risk from imaging and radiation. So let's give you an example of this. So we understand, based on the survivors of Hiroshima and Nagasaki, from the atom bomb survivors here, and we understand their cancer risk. And so we're talking induction of lung cancer. And along my x-axis here, I have exposure to that population, anywhere from 1,000, 2,000, 3,000 on up millisieverts. So these values are all greater than that 100 millisievert I talked about in my previous slide. These are pretty substantial exposures. The biggest difference between this group and the group down below, this lower group comes from a study of Canadian patients that received fluoroscopy. So now we're talking about imaging. They still received the equivalent total dose, 1,000, 2,000, 3,000, etc. But the biggest difference was, when you look at this line up here with those solid squares, you don't see the what? Sorry? Oh, yeah, thank you. Thank you. My apologies. Thank you. Oh, and just hold it down? Okay. Yeah, we'll just do that. Perfect. Excellent. All right. Should I start over? No, just kidding. All right. My apologies, especially for those. No one could see what I was pointing at. But so I was talking about this group up here. These are your survivors from Hiroshima and Nagasaki, the atom bomb survivors. These people received that exposure event. So let's say, for example, 1500 right here on this dot. They received it instantaneously. Whereas on this group down here, these folks, they were patients that were undergoing fluoroscopy. So they received the same 1500 millisieverts, but as we know in fluoroscopy, that would probably be the equivalent of maybe an interventional procedure for an hour, maybe an hour and a half, who knows? But it's not instantaneous. And so when you look at the risk on the y-axis, you can see that instantaneous exposure carries much greater risk than when the exposure event is drawn out over time. We call this the dose rate effect. And so this is one of the main reasons why, oh, I gotta turn that off. I cannot, there we go. Yeah, I guess I'll just use the keyboard. So this is the main reason why we don't, this is the main reason why we don't look at cumulative dose in imaging. It's because, yes, they may get the same exposure event of 1500 millisieverts in this one example. Their risks are not the same. And so people that get it instantaneously, which we can't give in imaging, the machines just cannot do that, versus those that get it over time. And so that's one of the built-in protections for imaging, is we give low doses over time, either during, for example, an interventional procedure that might occur over minutes to an hour, or someone that might come back one day, the next day, or 1 month to the next month to the next month. The opportunity for the body to heal itself, even within that short time of a couple minutes to a couple hours, actually helps reduce the overall risk. You can see here, this line is basically flat. Risk was basically consistently the same from very low to very high doses. All right. So basically what I'm saying here is exposure levels for medical imaging are relatively low. Risks of cancer induction from imaging is relatively low. It's difficult to absolutely know what that risk is. So to calculate absolute risk is difficult because of this latent period. There's so much that goes into our life. We call these confounding variables. So if you get exposed to radiation, let's say you fall off your bike as a elementary aged child, you bonk your head, you go in, you get a CT scan of the head. It would take anywhere from 10 to 30 years for a child to grow a solid tumor. We just understand that latent period. But that child, for the next 20, 30 years, could live a life that has various different variables, such as they could smoke, they could do any kind of things that would maybe potentially cause cancer to grow. And so we cannot rule out the lifestyle from the overall cancer induction at the end of their life, at that point of cancer diagnosis. And so we talk about risk as low, but we just can't absolutely know what that risk is. So if we understand this risk to be low, why are we bothering to collect all of this information? So I want to give two examples of this to kind of try to frame why we're doing this, going through all the trouble to talk about dose reference levels. So one example here for me and Dr. Canal, in the US, we have natural background radiation of about 3 millisieverts. So if you look at a map, there are certain areas within the continental USA that have just higher levels of radiation. I'm over here, it's kind of blue, so it's low. Dr. Canal's all the way up here. She's also probably relatively low. In this area, there's a lot of mountains in this area that have a lot of uranium and thorium, and so it just tends to be, and it's also higher up, so it gets more cosmic radiation. The overall average of all of this territory is 3 millisieverts. And then when you look at the overall dose population from, from medical imaging, so just on average, the average patient in all of the US gets about 2.6 millisieverts. And one of the things that we look at then is that exposure ratio. Oh, actually, I wanted to show one more thing, and then I'll talk about that exposure ratio. So what about here in Thailand? So according to a publication that I found that was done in 2014, the natural background radiation for Thailand is 0.3 millisieverts. And so I couldn't find a person, I couldn't find a publication describing the overall population average dose from medical imaging. But as Nepapong talked about, you guys have pretty much the same technological CT scanners and everything that we have in the US. You may use them slightly different. Your population is obviously going to be slightly different, but the likelihood of you having probably the same output is probably a safe assumption. So when you look at the US and you look at that dose from medical, which ours is 2.6 versus background, it's a ratio of about 0.9. And so the medical radiation, the exposure from medical imaging is actually a very small percentage. Whereas if we use that exact same value, that dose for medical, assuming you had the same technology and you had the same population, which I know is not a perfect example, that ratio for Thailand is a factor of 10 higher. In other words, though medical imaging in and of itself is relatively low in risk, it's still proportionately a very large part of the Thai lifestyle. And so why do we want to worry about medical dose? We want to make sure that the risk to benefit ratio is always properly balanced. So we talked about how risk is relatively low. So when we talk about imaging, we're going to focus more on the benefit that imaging provides to the Thai population. And the dose reference levels give us a way to level the playing field for all of Thailand. In other words, what we want to do is we want to make sure the benefit to risk ratio is the same if you're being imaged here in Bangkok or anywhere else in Thailand. And so even though we're talking about a overall low risk, we still want to make sure efficiency and optimization is equal. It's just a natural way for us to say that everyone is getting kind of that same, experience when it comes to imaging and medical care. Ultimately, when it comes to dose reference levels, once we start collecting information, we know what we are experiencing across the various different sites. Of course, Nepapong mentioned that you have now collected up to 9 sites, so this is great. So once we get this information, and we're going to spend several days talking specifically about the actual information, but just generally, what dose reference levels can help us do is not only do they help kind of make sure the doses are appropriately low, but you see here on this whisker plot right here, there's just a variety of different types of imaging. You might not even be able to read them. That's not really the problem, the reason I'm showing you this. You have dose on one side and the types of imaging exams on the other. But you see here, a whisker plot will show you the first quartile, the 25th percentile, the median value, the 75th percentile, and then the maximum value and the minimum value. So you can see for this exam procedure, you can see there is a very large variation of techniques being used. And so this is one of those ways that we can kind of help to reduce the extremes across all of Thailand. As everyone conforms to dose reference levels, it helps. The dose level in itself may come down, but ultimately the extremes will help come down. So what are the goals that what are some goals that we need to establish to set up a national dose tracking program in Thailand? Well, we need to identify the correct dose metric to track. Every modality will have its own, but specifically we're going to talk CT this week. We need to develop a central repository to collect, to curate, and analyze that data. We need to identify trends and establish the reference levels themselves. Once those are established, we need to go out and educate, and then we need to monitor response. So let's kind of step through those one at a time. So identify the correct dose metrics. As I mentioned, every modality will have its own, that's my next slide. Every modality has its own way to calculate radiation. And it's specific about the type of equipment. So for CT, we're going to have various different metrics, but then every CT scanner out there, there's going to be different manufacturers, different years they were built with different levels of technology. They're all going to have various different levels of radiation factors. Of course, every hospital may have its own unique technique factors, and those will drive the different exposure levels. And then, of course, patient demographics. There may be just a subtle difference in population up in the northern Thailand versus central versus southern. And then we will, obviously a lot of this talks about output. We will draw that link. My very first slide was how does image quality and dose connect? We will spend a day talking about that on Thursday. And then on Friday, we'll talk about more specific dose optimization techniques. So as I mentioned, every modality, this is what I meant to show you in my last slide, but every modality has its own version of ways to calculate or estimate radiation output. So Nepapong mentioned, moving forward with your DR, you're going to talk about CAP and DAP. Not talk about, but you're going to collect that information. We are specifically, of course, talking this week about CT. And after me, Dr. Kanal is going to Kalpana is going to talk about the various different CT dose index values. So what is a dose reference level? We've talked about this now for many years on these missions, but just as a quick reference, there are a few terms that you will see quite a bit. One is called the DRL quantities, and this must be, so a DRL value or quantity must be something that is readily available and measurable. And that is why, as Nepamong mentioned, you collect effective dose, but you don't actually use effective dose, because effective dose is not something you can physically measure. You can measure CAP or DAP for X-ray, and you can physically measure CTDI, as I demonstrated on the last slide, for CT, but whatever we use for dose reference levels, they have to be something that we can physically measure. The IAEA recommends for CT, CTDI vol, and DLP, which, as we saw a moment ago, are the two metrics that are being collected and used here in Thailand. SSDE is not currently recommended by the IAEA, but it is it's about a 10-year-old now metric. And SSDE is an update to CTDI vol. Once again, Kalpana will give us more information about that in coming talks. I recommend collecting SSDE. In this room, every one of us, we're different body sizes. It's just natural by the population that we should be able to account for radiation dose as a function of body size, because most scanners today, the radiation output is dependent on patient size. We don't use the same technique factor for everyone anymore. That's a kind of an older style of imaging. And SSDE in the coming years is going to be actually listed on CT scanners. I have a chance to work with the IEC, and they're the body that creates the technical regulations and parameters for all the manufacturers. And they've been working for the last 10 years to define SSDE. And going forward, as you probably know for all the technologists in the audience, when you look at a CT scan, they'll list CTDI and they'll list DLP. Going forward, we're now going to start seeing SSD also listed. So though it's not necessarily recommended currently with the IAEA, I recommend as you build this process up, I would start with SSDE, because I think in the near future, in the near short-term future, we should see that become a recommendation for DRLs. All right, we need to develop and collect. We need to develop a repository and start collecting. So, you know, obviously this is just an introduction. Nepapong already kind of introduced this. You're collecting from now 9 facilities around around Thailand, with the idea to expand to 8 more as you got this new grant, which is a wonderful, wonderful revelation. And then most, if not all, as I understand it, are using Radiometrics to collect the data at the specific hospital, and then they use that to then, of course, send that over to the OAP. So Radiometrics is a great tool. I actually, in my hospital, we have the Bear Radiometrics, But there are actually quite a few options available. There are, at the time I looked at this, there were, I think, 18 or 19, but there's probably even more in the development. So every hospital could technically have their own dose management software, but they just have to be able to collect the right dose for the right modality and be able to send that off to the OAP. Pretty much all of the options out there will do that for CT. That's not a question. But when you start to look at other modalities such as fluoro, mammography, DR, not all of those imaging softwares, the dose softwares, will collect for that. So you have to just be careful which ones that you do select. We have an entire talk dedicated, I think, tomorrow or Wednesday on going over dose monitoring. So I'm not going to go into the detail about this. Of these 18 or 19-ish softwares, those are things you have to pay for. You set up a license and they work with you to help you establish it, etc. There are some open source ones. So for hospitals that maybe don't have the funding for it, or if there are physicists and technologists that want to start this as an initiative, but they don't have, the funding from the hospital to do it, you can actually go on and download various different sources from the internet. There's 3 that I'm aware of. Once again, I'll go over those in a couple of days. One of which, for example, is called OpenREM. It basically covers all the modalities but nukes and PET. So the ones that are free, they are still actually pretty robust. They can cover most modalities. The things that you need to consider once you get the softwares installed in your various different hospitals is you need to go through this process of validating and preparing the data for submission. So for Thailand specifically, there's a process that it has been established so that the data can go off to the OAP. Before you do that, we need to label the data. So RADLEX is something that has been adopted here, where we basically take the data and we look at the way it's labeled at the hospital, and we need to come up with a correlation to a specific value that's listed as example in the RADLEX. So we could have, you could have various different naming schemes in a hospital. You don't have to necessarily rename everything on the CT scanner itself or on your master protocol lists, but you do need to make those connections. And you need to make sure that the connection is equivalent. So for example, a head CTA is not going to be equivalent in radiation dose as a routine head exam or a routine brain exam. And so you have to make sure you select the right RPI, the right ID value, so that when the values go up, the values are properly connected at the level of the dose registering server. All right, and then of course you have to make sure you get the right values if you're sending for adults versus for pediatrics. The dose levels could be different, and so you need to take the time to get the data in the correct order and in the proper manner at your hospital site. And then, as this is what you see on the screen is an example of how we do it in the ACR back in the US. Obviously, the OAP has their formal version of doing this, but the process is largely the same. So I just wanted to demonstrate it, where you're going to go from collecting the data on the scanner. In our hospital, my specific example, once the technologist ends the exam, the data is sent to PACS and the data is sent to a server, a dose monitoring server. And that dose monitoring server collects that data and it goes through a process to anonymize it. So it strips off the patient demographics, name, the medical record number, all those things, and it pushes it to the ACR, which is kind of the equivalent of what the OAP is doing here within their within their dose tracking department. And so once it hits the ACR, then the ACR will have their own team of statisticians and whatnot that'll take that data, they'll collect it, they'll analyze it, they'll generate reports, and then those reports will then go back to the hospital. We get ours every quarter, as you guys do here in Thailand. So the way you want to do this, of course, you want to identify the most frequently ordered imaging protocols per modality. So establish the 10 plus your 4, unique to Thailand, which is great. You need to come up with a standard lexicon, which you guys have done. There are a variety of different ways, and this afternoon after our break, we're going to talk quite extensively about this as just a refresher and as a training for maybe those that haven't gone to the process of doing the mapping for protocols for standard protocol mapping. That's what I'm trying to say. The nice thing about this is that this RSNA Radlex playbook is free. And for the longest time, there was a LOINC, or Loinic, and RSNA. They were two separate playbooks that were going in parallel. And as of, I think, 2021, they finally came together. And for many years, they were working together as a committee to try to marry the two together. But I believe as of 2021 now, they are one. So you go to the website and they're all together. So, and it's a free option. It's great because you can go on as Nepapong showed in one of his slides. For us, it's absolutely essential in the US that all data leaving the hospital is anonymized. It's a law. And I heard, as Nepapong mentioned also, that is similar here. And so you have to make sure you take the time to strip the data of anything that could have some patient-specific identifiers. We collect that data, we send it to that repository for analysis. Now, what happens if you don't have software to do all this? But that doesn't necessarily mean you can't be included. It just means that it's a more difficult process. And I know in the early days, the way the Thai government developed their very first DRLs, it was actually all, as I recall from our first mission, it was all paper surveys. So that's still maybe a possibility. It's obviously a more personnel intensive because you can create actual documents, you send them out, people at the hospital will have to fill them out and send it back, and then people then would have to digitize those. If you look at the ICRP 135 recommendation, they say if you're going to do papers and you're not doing, or surveys instead of doing digital with just the servers, you have to do, they recommend anywhere between 20 to 30 patients for fluoro and CT per procedure. So if you had say you had the 10 plus 4, then you'd have to, of course, multiply that. So you'd need about 120 something patients to do. And then if you're doing mammography, they recommend a little bit more. So you want to, the ICRP 135 also recommends that to establish national DRLs, you really should have somewhere around the 20 to 30 facilities. So you get a good average across your national population instead of it being skewed towards, if everything came from Bangkok, then the doses would be skewed to the technology and the population here in Bangkok area. And then the goal is to survey a minimum of somewhere between 30 to 50% of all national imaging centers. So that's a lofty goal, and I know that the Thai delegates and the Thai government's working towards that to get upwards of 30 to 50%. When you do this, though, you need to make sure you get a good cross-section of types of hospitals. And so Nepapong listed out the variety of different hospitals, be they private or government, and the various different sub-examples of different government and private hospitals there are. So this is just a quick example from one of the dose index, the dose registry reports I get back from my hospital. It breaks down the types of hospitals that were included in that quarterly report. You can see the number over here. In this case, you can see community hospitals always are going to be the largest percentage. And then after that, you can see academic hospitals, which we are one. There's children's hospitals, we're actually both, so we fit in both of those categories. The point here is you just want to get a good distribution across you want a good distribution across all the different types of hospitals so that you're not skewing your data one way or the other. All right, so we talked about DRL quantities, that you need to make something that is you need to pick a value that is measurable and trackable. Another thing that the ICRP 135 document defines is what's called a DRL value. And this is something where, statistically speaking, when we collect the data, we are looking at the median dose value, not the mean, and we're looking at the 75th percentile data, or the third quartile data. Those are the meaningful values that we will use when we discuss DRLs. And then they define something called a DRL process, which is that whole cyclical thing that Nepapong showed, that you collect the data, you analyze the data, you report back the data, hopefully something happens at the site to make some positive progression, and then its process starts again. So this is kind of the cycle for the DRLs. When we talk about CT values, we're going to look at kind of every 3 to 5 years, you want to be refreshing those DRLs. And that's just largely because, as in my personal experience, technology changes every 5 years, give or take. I don't know to what extent every hospital here would change that technology every 5 years, but as some hospitals adopt newer CT scanners, you will just see that change in dose over time. And so the DRLs need to reflect that change in technology. And then finally, there's going to be a term called achievable dose. And this is at the 50th percentile. So we are collecting the median, which is the 50th percentile, the 75th percentile, which is defined as a DRL. And then there's something called an achievable dose, which is the 50th percentile. We will talk more specifically about this. Dr. Canal has a talk specifically talking about all of these and how they relate to a DRL tomorrow. But just understand that those are there, and that's something that we need to establish when we send out these reports. How do we interpret the DRL values and how we set the trends is something that you need to establish a dosimetry team. And we'll go over that, of course, in the coming tomorrow. But every hospital needs to have something in place so that the data, when it comes back to them, it can be used meaningfully. All right, and then there's the education component. The report going back to the hospital needs to provide some kind of tool to allow that hospital to meaningfully grow from the data. And we can break that data down by region, by institution, by the different types of metrics you have, by protocol, anything and everything. It's data. You can kind of cut it, you can mix it, you can match it, you can provide it to this hospital in many different ways. But because you can also do that in so many different ways, you have to be careful you don't overwhelm the hospitals. You have to give it in a very precise way. So for example, this is a plot that we get. It's our 10 most common. Here's the list right here of protocols. It gives the whisker plot. So it gives your ranges and then your averages. And then it shows you, in our case, you see that little red line right there? That's my hospital's value. So the box plots are the national DRL levels, and those lines are where my hospital falls when you look at these types of protocols at my hospital. So just visually, it gives me a quick and instant response to where I am as a hospital. Obviously, there's going to be tables and a lot more data where I can start to dig into it. All right, Impong already showed you this, but I think this is a very interesting process because you go to the UK, they've been doing this for quite a few years. They've actually been collecting data and processing it for dose reference levels since the 80s. And when you look at the success they've had over the last few years, you can see when you compare 1980 to 2005 and 2000 to 2005, they have reduced their population radiation dose pretty substantially. When you look at the larger time frame, 1980 to 2005, they've reduced their overall population dose by 50%. But just in the more recent 2000 to 2005, they were still able to get another 16% reduction. So the point is when you take this cyclical process seriously, you can actually see meaningful changes that can help affect keeping risk very low and keeping the overall process, the benefit to risk ratio, equivalent across to all of a country, in this case UK, and of course what we're talking about is Thailand. We want to take this data, we want to obviously compare it to regional, so maybe Chiang Rai versus Bangkok or other equivalent centers of population, and that's a very good thing within the Thai dose reference, the dose registry. But the other thing that happens is once you start to collect all this data, you can now start to look at yourself more globally. And so you may find that your hospital is lower than or equivalent to the dose reference levels here in Thailand, but then you might notice that, for example, Thailand might be higher than, say, I don't know, Japan or etc. And I don't know that for certain, but you have the opportunity now to start comparing nationally. So Thailand becomes a player on the international stage as they publish and develop their DRLs. So that's helpful for you as a country to obviously gain the ability to gauge yourself comparatively, but also gives other countries, especially here in the South Asian region, a benchmark for them to help compare to. So it's a process that kind of help everyone grow. All right, and I already mentioned that last thing. So just in conclusion of what we've been talking about for this introduction is why do we establish DRLs? The main reason here is we want to maximize the efficacy of medical imaging and optimize patient radiation dose and image quality. And I know we haven't talked image quality, but we will talk about that. So you notice here I didn't say risk anywhere. I've already kind of laid out the idea that risk is very low in imaging, but we still need to make sure we optimize so that the process, that benefit to risk ratio, that efficacy is always maximized. All right, and then we want to minimize radiation dose to staff and of course maintain safe conditions. And obviously we want to do this for the most vulnerable populations, for children and some adults that have the greatest risk because maybe they're chronic disease, so they have to continually be imaged. So anyway, that's just an introduction. We will at this point kind of go on and we're going to get more into the minutia. We're going to talk about specifics. At this point, I guess we'll turn the time over to Dr. Kanal and she'll talk more specifically about CT.
Any questions or comments from the audience อาจารย์ปานมีอะไรไหมคะไม่มีอาจารย์เพชรมีไหมคะ Okay. So Dr. Kanal, if you want to stand up and talk, that's okay too because we have another video here that yeah.
All right, good afternoon. Before I start talking, I just want to take this opportunity to thank our local hosts for inviting Sam and me over here, and also to IAEA for helping us to travel to Thailand. Well, over here it's opposite. Okay, thank you. All right, I should be looking back, I guess. That's the moral of the story. All right, after that excellent talk by Dr. Brady, I am actually going to deep dive a little bit and talk about CT dose metrics. Please stop me if you have any questions during the presentation. So again, I think Sam did an excellent job talking about benefit and risk. I'm going to talk specifically about CT. Why is CT dose of concern and why are we going to so much trouble to monitor the dose? So this is a graph of the number of, oh, I forgot my glasses, sorry. So this is a graph of just showing you the number of procedures, and this is in the United States as a function of year. And you can see, I don't have a more updated version, but in 2006, the number of CT procedures that was being done in the United States was about 62 million. That's a lot of CT. And now I would say that number is probably up to 80 or 90 million, but now it's instead of rising, it's actually more like plateauing out. So I think we may have reached the maximum utilization of CT, especially now with awareness of dose and monitoring and things like that. I think CT is really being paid a lot more attention to, but this increase was just ridiculous. Like every second medical examination radiology was CT. Sam pointed some of this out. There have been some radiation overexposures that made CT got a really bad reputation in the United States in the early 2000s when there were some radiation exposures. There were two that I want to mention. One is this little child, as you can see. I don't know if it's very clear for those sitting at the back of the room or online, but you can see the skin erythema on this child's face. And what happened in this case was this kid had fallen and the parents brought him to the ER to get a CT because they were worried of some internal injury. And the person scanning the child, there was something wrong with the machine and they kept hitting the scan button instead of stopping and trying to figure out what is going on. And I don't remember the numbers, but basically the child got a lot more than one head CT in a very short interval of time. And so you could see the effect of that. They had so much dose that it caused a tissue reaction. The other case was stroke patients at Cedars-Sinai Hospital in California, and where the technique factors in the CT scanner was set incorrectly, which resulted in overdose to about 206 patients, due to which, there was a lot of hair loss because of those overexposures. And this is the stroke patients. So they do a head perfusion exam. So same area of the skin, they scan over and over again. And because the dose was so high, you can see hair loss. And Sam showed these earlier as well. So these were some of the overexposures that we saw in CT in the early 2000s, again, giving a bad reputation to CT. And, we used to have headlines in the United States saying CT is killing your children, which is pretty provocative. And that's not true. As we mentioned earlier, Sam mentioned earlier, the risk is really low, actually, if CT is done correctly. So as I mentioned, the overdose in some of these cases was between 4 to 13 times higher than is typical for these exams. And this could be due to several reasons. It could be because the CT scanner is not performing correctly, the need for prettier images, you want to reduce the noise, so you increase your dose, or serious lack of operator knowledge, which happened in the case of that little child who got scanned over and over again. Instead of stopping, the person running the scanner just went on scanning the little child. So all of this can contribute to doses or overdoses in CT. And of course, this dose can vary significantly depending on what scan parameters are being used. So in order to be able to monitor dose, we need to understand what we monitor. As mentioned in the previous talk, depending on the modality, you may be monitoring different things. And again, you want to monitor things that are achievable and measurable. So what I'm going to talk about for the rest of this talk is some of the CT dose metrics that we should be monitoring for CT. So this just gives you an overview, and then we're going to go through each one of these, or at least the ones that are important. So we'll start with the CTDI, CT dose index, or CTDI. 100, we'll talk about weighted volume. I'm going to talk about dose length product and effective dose. So in the real world, here's the dose distribution for a patient who is undergoing CT, right? So they're going through the scanner, and the dose is building, where it reaches a peak dose, and this tails down because you have scatter as well coming from the different slices across this patient. So CTDI is really an integral under the radiation dose profile, which you can see right here, along the z-axis, which is along the patient, from a single axial scan that you do when you're collecting the dose data. And NT, all NT over here is, for those of you who may not be familiar with the technology, is just the nominal beam width. So it's the number of elements, detector elements, times basically your detector thickness. Thank you, Sam. I'm getting old. I forget. All right, so let's talk about CTDI. It basically represents the average dose along the z-axis. And can you see my pointer? Okay. So it represents the average dose along the z-axis, along the patient, from a series of continuous irradiations. So, as a patient is going through a scanner, you're not just doing one scan, right? The tube is rotating around the patient till it's covered the area of interest, so contiguous irradiations. And CTDI 100, it basically represents this accumulated data at the center of a 100 millimeter scan. And how do we do that? How do we achieve this 100 millimeter scan? Well, we use a CT chamber that basically is of 100 millimeters, as shown here by this diagram. We have two different phantoms here, and the basic CTDI 100 measurement involves the use of this 100 millimeters or cylindrical pencil iron chamber, approximately 9 millimeter in diameter, inserted at different regions or holes around these phantoms, and then you collect the data over, the center of that chamber. So for those of you who may be familiar or not, this is the 32 centimeter phantom, which we use to calculate body doses. And then this is the 16 centimeter phantom, which we use typically to calculate head doses. I also put in another column here just to show you the different SI units. The most familiar, I think in Thailand too, you use SI units. It's a gray is what we use for CTDI wall, and then we'll talk about the rest as we move on. So CTDI 100 is a measurement that physicists make, or depending on which country you are, maybe the technologists make, when you're actually near the CT scanner, you've got your measurement and that's what you're measuring. But really that's not what you see on the CT scanner or displayed on the CT scanner. This just shows you a measurement setup. Here on the left is the 32 centimeter CTDI phantom, as I said, to measure body doses. And you can see really nice, newer scanners, newer phantoms you buy, you have them nested where you could put the little phantom and then take it out when you just need the larger phantom. And here is just the 16 centimeter phantom by itself. Now, the reason we do measurements is, of course, to calculate the CTDI, but just to keep in mind here, this is showing you the two phantoms, the 32 and the 16 centimeter, and you're looking at dose readings at 2 points. One is right at the surface, 1 centimeter below, and then right at the center. And the dose distribution depends on your phantom diameter. So when you look at that larger phantom, the 32 centimeter, you can see that if it's 100 is the reading at the 12 o'clock position, it's close to 50 at the center. And why is that? That's because of attenuation, right? The X-ray beam is traveling through all that, in this case, phantom material, or in case of a patient. And so by the time you reach the center, you have attenuated half of your photons. So typically when you're using the larger phantom, it's more like 2:1 ratio, right? The surface is much higher than the center dose. But that's not the case when you're using the little phantom, the 16 centimeter phantom. It's very little difference. It could be almost actually the same. And of course, in this diagram for illustration, it says 90, but you could even be measuring close to 100. So it's a 1:1 ratio. That's why it's very important when you're looking at CTDI dose displayed on your scanners that you know what phantom they're talking about, because it makes a big difference in when you're comparing 32 to 32, or you're comparing 32 to 16. And that has happened to physicists, right? Where they have a patient who came back, got scanned on a different scanner, and then they're like, why is the dose higher on scanner B versus A? Well, the scanner B probably was displaying the dose for the 16 centimeter phantom versus scanner A, which was doing it for the 32 centimeter. And therefore, it's incredibly important for physicists and technologists to be aware what phantom size you're referring to. So that was CTDI 100. I talked to you about the different phantom sizes. Let's move on to CTDI weighted. So I said we measured the dose at all of these 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock, and center. And from that, you can then measure what's called the CTDI weighted. And all of these CTDI weighted, all of them are basically talking about the radiation dose absorbed by the patient's body. And I actually will cancel out patient and say really by phantom, because this is really not talking about the patient. This is to a phantom, but people always use patient instead of phantom. And the way the CTDI weighted is measured is you take 1/3 your measurement that the physicist made or the technologist made at the center of the phantom, and then 2/3 on the periphery, and you calculate the CTDI weighted. How often do we use it in practice? In the United States? Not really. I mean, the scanner doesn't even show you CTDI weighted. It really shows you the next one that we're going to talk about, which is CTDI wall. And the reason we are more interested in CTDI wall is because now it's taking into account the pitch. You know, how fast is that table moving into the scanner, and are you scanning contiguously? Do you have gaps in between slices, or are you doing overlap slices? So you need to make sure you're taking that into account, because that will impact your dose. So CTDI wall is the most important CTDI parameter out of all the ones I just talked about, because it's talking about the pitch as well. And it is the approximate average radiation dose over all the axes of the patient XYZ. And as you can see over here, I canceled out patient and I said phantom, because really we're doing the dose to the phantom. It's not really to the patient, even though a lot of people will use it as that. So this is one of the dose metrics that, as Dr. Brady mentioned earlier, you want the dose metric to be measurable and available. And CTDI wall is one of them that you want to use to set up your diagnostic reference levels. And that's what I'm pointing to over here. So again, and very important to know what phantom size, and I'm going to repeat this a little bit because it's so important. So this shows you 3 different phantom sizes, and I mentioned 32 and 16, but you also get a 10 centimeter diameter phantom, a little baby one, which can be used for pediatric or smaller patients. And you can see here that the measured dose, depending on the phantom, going from a smaller phantom to a larger phantom varies. So the 10 centimeter is giving you 47, the 16 is giving you 37, and the measured larger is giving you 18. And that's just based on the formula and the attenuation with the larger. That's why your measured is very much lower compared to the little baby phantom. So measured CTDI wall can increase 2.6 times as phantom size decreases. So it's very important that you keep that in mind. And that also kind of relates to the fact with actual patient sizes. That means that if a patient is smaller, a pediatric patient compared to a larger patient, you have to worry that the dose is going to be much, much more to that little patient. So moving on, so we talked about CTDI wall. Now let's talk a little bit about dose length product. That is an indicator of the complete dose for that entire exam, because not only is it taking into account what the patient/phantom has absorbed, but it's also taking into account the scan length, which is really important as well, because that's really what is an indicator of risk. So DLP is your CTDI wall times just the scan length. If you're doing a whole chest, are you doing a whole abdomen, are you doing chest, abdomen, pelvis? So it takes into account the region of the patient, if you will, even though it's really a phantom, that you're scanning. So why is it important, DLP? Because it really represents the biologic risk. So in this example, you can see, even though the CTDI wall is the same, about 20 milligray for 10 1 centimeter slices to this patient, in this particular case, the length is much smaller and the dose is about 200. But in this case, you can see it's twice the area of the patient that you have scanned. So your DLP is actually twice of what this patient got. And therefore, more coverage of the patient, more risk, because there are more organs that you're going over. And that overall is contributing to the effective dose to that patient. And therefore, it represents a greater biologic risk. And so in my experience in the United States anyway, physicists think in terms of CTDI wall, because that's the ultimate for us. That's the amount of dose going in the patient. But when you talk to the radiologist, and I'm sure you might agree with me or not, they think in terms of DLP. So they look at the DLP, the radiologist, because they're thinking risk. But when they talk to me, I'm thinking, no, wait, I need to know what the CTDI wall is to see if that's appropriate for the exam, right? Because the scan length is typically fixed for a particular examination. So they think in terms of DLP, and physicists think more in terms of CTDI wall. So it's very important to understand that both people are talking about important factors. They're talking in terms of risk, and I'm talking about what's going inside the patient's body, because the risk is only equal to what's going inside the patient's body, right? If I lower what's going into the patient's body, the risk will decrease as well. So it's something when you talk to radiologists, you have to keep in mind the terminology being used. I think a lot of us, or most of us, have seen what a dose report looks like, and what I just mentioned, this is showing you actually from General Electric. It's a CT abdomen without study, and it shows you the different, the arterial phase. It's probably a 3-phase liver study, arterial phase, venous phase, delayed phase, and it shows you the series, the type of scan, helical, axial, scouts you don't need to worry about, very low dose, what's the scan range, and then here are all the CTDI wall, and here's the DLP. One thing you have to keep in mind that CTDI wall cannot be summed up like we do DLP. Okay, it's very individual to a specific area, and you can see the CTDI walls, and here is the DLP for the whole exam. all right? But more importantly, you can see what phantom size is being referred to for these calculations. If it was a Siemens scanner, this is typically also 32 centimeters, but they use 32 for everything. If it's a head exam on a GE, it's typically 16 centimeter phantom. Again, if you have, like I do, I have GEs, a mix of GEs and Siemens scanners, I have to keep thinking, okay, this is what GE shows, this is what Siemens shows. And when you're comparing the dose, you want to make sure you are normalizing to the same phantom size. All right, so standardized method to estimate and compare radiation dose from 2 different CT scanners to the same phantom is what you're using really CTDI wall from. And CT dose index, it's all great, it all works, and this has been established years ago for really small fan beams, 64 slice and smaller really, but now we are dealing with 256 slice scanners, 320 slice scanners, and that kind of breaks down a little bit, and the vendors tell you how to do that calculation because they have or even though they're 320 slice scanners, when you're doing your dose measurement, you just use the 40 centimeter or the 40 slice to get a more realistic number for the CTDI. There is a task group report from AAPM that goes into details of how you can make adjustments or correction to your CTDI if it's a larger beam width. And again, I've mentioned this a few times. I just want to emphasize that the displayed CTDI on your scanners is not phantom dose, even though everyone thinks it is. It's really the dose to your 16 centimeter phantom or to your 32 centimeter phantom. And we as humans don't look anything like those phantoms, right? First of all, we are larger in many cases. We have organs, we have different attenuation. That's just an acrylic phantom. So keep that in mind, that the displayed CTDI is representing really dose to a phantom, not to a patient. Now, one way of determining risk easily or on the fly, especially for radiologists if they're interested in that, is calculating the effective dose, unlike the way a physicist would calculate, where you go pull up your Monte Carlo program, put all the parameters, and then you get effective dose. Well, you're not going to ask a radiologist to that, or even a technologist to do that. So one way to do it, a reasonable approximation of effective dose, you can take your DLP and you can multiply what's called a K factor to kind of come up with an effective dose. Because if you're thinking risk, and if you're trying to compare, say, the CT of a chest to a CT or to a chest radiograph, one way of comparing is looking at effective dose from both those exams and seeing which is lower. I think it's a no-brainer that the CT is going to be higher. But if you're trying to compare to other modalities or you're new in the field, great way to quickly look at what the effective dose is. So the table over here shows you, here's the formula, but the table here is from one of the AAPM reports, which for some reason I forgot to refer to, but it gives you the K factors for the different anatomy or region of body. And then for children, 0-year-old, 1-year-old, 5, 10, and then you notice it goes all the way to the adult. So anyone over 10-year-old, depends on you. You want to treat them as 10-year-old or as an adult. Again, these are approximate numbers, and you can multiply that by the dose length product and get your effective dose. But you notice on CT scanners, effective dose is not displayed, right? It was not meant to be a risk from exam. It was more supposed to be for professional workers, but people use it. It's not a bad thing to use if you're just kind of trying to get a feel for risk, but I wouldn't, use it for more than that. So we talked about phantoms, but we are all people. We want to know the dose to a patient. So AAPM, report 204, actually goes one step further and takes that calculation from the phantom to the human being. So from a DRL point of view, we want to monitor CTDI wall, we want to monitor DLP, and as Sam mentioned, we should be monitoring SSDE. But right now, as of this moment, none of our CT scanners display it yet. So you could, if at some point it's displayed, and I'll talk a little bit about what your dose monitoring system can do for you, one thing you can do is your dose monitoring system will look at SSTE. So you could look at that and monitor that. And I think it's incredibly important because this really represents patient dose compared to the phantom dose. So the report came out in 204, came out a few years ago for both pediatric and adult body. And then they came out with head in, I think it was more like 2019 or somewhere there. So there is also head SSTE now. So to get a more specific patient dose estimate, medical physicists derived a quantity called size-specific dose estimate, or SSTE. And all it does is it takes this, there's a conversion factor, which I'll talk about in a minute, multiplies it by that dose that you got from the phantom and gives you a more realistic number for what this patient would be getting as a dose. So what the report did is basically tried to approximate the size of a patient by looking at what's called an effective diameter or lateral dimension of a patient, or AP plus lateral dimension of a patient, and try to come up with a more realistic number. So here's one example of effective diameter, which is basically the square root of the AP dimension times the lateral dimension of the patient. So that's great, right? You're actually looking at the scout or the localizer of the patient, and depending whether it's me or a 400-pound or a 300-pound patient, that AP and LAT is going to vary. And you're taking that into account in your calculation, which makes sense. And you are now trying to incorporate the patient into your dose estimation, which really has been lacking until recently for physicists. You know, we do a lot of hand waving when we talk to our radiologists, to our patients, here CTDI, but it's not really patient to you, right? It's more of a general number that we give out when we talk about dose. So the great thing about this report is it gives you all these conversion factor tables that are based on phantom size. Both 16 and 32 are available. And I want to show you an example here. And it's also dependent on what dimension you have available. So if you have the lat plus AP and you can easily calculate effective diameter, you can look at that. If you just have the lateral dimension, so if you don't have this automated, you can just go to the scout of the patient. You can actually do a measurement and calculate the lateral dimension or the AP dimension. And anyone can do this and go look up the factors. So the report has many different tables. And here is just an example for a 32 centimeter phantom. And you can see here, as the patient's size is growing larger, your lat and AP, and you can see the effective diameter going larger, you can see that the conversion factor is actually going smaller, which kind of makes sense. The smaller patients, that's why the dose is going to be much higher, right? It's a factor of about 2.5 times higher. So in reality now, the CTDI wall is under-representing or underestimating dose for the smaller patients, and it's probably overestimating dose for the larger patients. So it's not really a very good quantity of which SSTE is, because it's really taking into account the patient size. So you can see tons of these tables, and you can go look it up. As Sam mentioned earlier, it's not yet available on the CT console, where it would do this calculation at the back end and just show it to you, which is so much more useful for all of us. So now the physicist has to go in, look at the scout, do a calculation, or your dose monitoring program can do that and give you what the SSTE. And I think it's more important for pediatric patients, and I'm sure, Sam, you use that a lot when you're doing consulting with your pediatric patients. Sam is a physicist at a pediatric hospital. I also cover a pediatric hospital. I also cover a trauma hospital. I also cover academic. So you see a whole range of what you're going to talk to the parents or to radiologists or other physician, depending on your population. And I think this SSDE becomes even more significant for pediatric patients, which I would definitely make use of in trying to really get a better idea of risk to that pediatric patient. So here's an example. Let's look. This is for 16 centimeter phantom table. Here is a patient, and their CTDI wall to the 16 centimeter phantom was about 9.29 milligray, and their dimension over here is about 168 or something like that millimeters. So if you round it off their lateral dimension, if you round it off to 17, so remember there are different tables with different parameters here. So I'm looking at the lateral dimension, rounded off to 17 right? And the correction factor is 1.08. So you take the CTDI wall, you multiply it by 1.08, and it didn't make much of a difference in this case. The SSD was 10 milligray. But if you had done it for, say, a much smaller patient, then that factor would have been much higher, and the dose would definitely be a lot higher. So this is another tool that we have that we can use to come one step closer now to actual estimate of patient dose, which is fantastic. And of course, that's until that shows up on our scanners, unless you have radiation dose monitoring system. One other way that physicists calculate dose is using Monte Carlo simulations, right? We all have software where we go in, we pick the region we want, and of course, patients don't look like this, right? All nicely standardized with exactly same lung size and no, but it at least gives you some idea of the dose, and you do those calculations and figure out the dose to your patient and to the different organs. And we still do that, and I think we'll continue doing that till we are at some point sure that what we read out of the scanner is the way to go, and we don't need to do this. But until that happens, we rely a lot on these Monte Carlo simulations, which is all it is computer simulations to figure out or an estimate the dose. So I think I just have a few more slides, but just kind of give you an idea. Those were the parameters we want to be aware of. And when you're looking at dose estimates and when you're looking at risk, it's more effective dose you're looking at. And to point out why is CT so important, here is a table from it's a Bible that we use in America, and I don't know if you use it here, it's Bushberg. It's a great book, textbook, wonderful book for physicists. And it shows you the comparison of different type of doses between the radiographic procedures and CT procedures. So let's just look at the skull. The dose from X-ray of the skull is very, very low. It's about 0.14 millisievert compared to the head CT, which is about 1.6 millisieverts. So the point I'm trying to make here is that not only is the utilization of CT high, but the dose is much higher from CT compared to X-ray, right? And therefore, everyone is monitoring CT dose. Not to say that the radiographic dose is not important, but it's much lower compared to the CT dose. And then other anatomy here that you can see the dose. I show this graph or this table to the residents, the radiology residents, because they need to understand the difference in magnitude of dose from radiographic procedures versus CT. Again, here's another Mettler paper, which also gives you the different average doses for the different types of exams. But what I want to point out here is look at the variation in the literature, right? Let's look at chest. 7 is typical, but it can go anywhere from 4 to 18. And I think establishing DRLs will hopefully bring down that big range that you have the plus or minus from an average value. And at some point, we hope it'll be 7 plus or minus maybe 2 or 3 at the most instead of 4 to 18. So again, gives you a really good idea of there's so much variation in dose across the country and across the world, with CT. And again, other very important part of CT that I get a lot of questions on is the dose to the fetus. And I think radiologists need to really be educated about that because they're the ones answering the patient, whether the patient came in through a regularly scheduled exam or if they came through a car accident, they're in your trauma hospital and they're trying to get, radiologists trying to determine, should I give this patient a pelvic CT because they look pregnant, they can't talk, they're unconscious, and should I do that or not, right? So it's very important for them to be educated on fetal dose. And I just kind of wanted to point that out here since we're talking CT. If the fetus is not in the field of view, don't worry about it. It's no risk to the fetus. I get my head radiologist, my neuroradiologist always asking me, I have a pregnant patient. I'm like, go ahead with the scan. Don't worry at all. No risk to the fetus. Even if the fetus is in the field of view, doing 1 CT, doing 2 CTs, doing 3 CTs, even maybe doing 4 CTs, it's no risk to the fetus. You have to cross a certain dose to cause any problem to the fetus, which is a whole different lecture. But the point I'm trying to make is 1 CT is not going to cause harm to that child or to that fetus. There's so many more natural risks for that pregnant mother that doing a CT is not a problem. Of course, you have to monitor and make sure your dose is optimized. I think the numbers in this reference are very high. I don't think we in our institution give 25 milligray from one abdomen CT. This is also an old reference, but the numbers are still very conservative in the literature. I bet you we are more around 10 or 15 milligray with all the bells and whistles we are using on new CT scanner, iterative reconstruction, optimizing our tube current modulation, optimizing our KV. There's no way we're giving 25 milligray. But again, a good number, as I tell the residents, keep in mind the radiology residents, because when they're talking to patients, then they have an idea how to explain it, that there's no risk from the CT. And then in comparison, here is X-ray and fluoro. And again, the doses are so low, nowhere near levels that you would have to worry about a patient not getting a CT when they're pregnant. Again, remember always balancing risk versus benefit. We're ordering the CT because there's a benefit to the patient and to the mother and maybe to the child. You're not just ordering it for fun, right? So the risk has to be balanced with the benefit. So in summary, CT utilization has grown significantly in the last decade or so. I think it's kind of, at least in the United States, I think it's plateauing out now because of everyone's awareness of CT. It has caused a lot of concern in the past, and it should always be of concern, and that will drive you to optimize your CT protocols. It should be monitored. CT dose needs to be monitored using the dose metrics I mentioned. In terms of DRLs, CTDI wall and DLP are the most frequently used metrics, and hopefully SSDE, once it's available on all scanners, will be included in that monitoring. And you should be familiar with typical doses from CT exams as well as dose to the fetus so that you have a good idea, when you're advising radiologists or technologists or medical students that when is it appropriate not to do an exam or when it is appropriate to do an exam. Thank you very much.
Thank you so much, Dr. Cannell, for your excellent lectures. Any questions, comments from the audience?
From my experience here, like not many physicists around, and then when it comes to the fetus dose, even like from plain radiography, I told them I don't need to do calculation because as long as the dose is lower than 10 milligrams, it's just like no need, right? But the doctors, they insist they need to do it.
Yes.
And then we end up have to do it all the cases, even chest X-ray. Like so what? So I think the degree of worry that the mother has is very extreme here in this case, and
Absolutely.
I think those management software help us a lot these days, especially for CT. Before the DMS come in, I have to use like CT Expo or whatever, and it's quite tedious. So the thing is, risk communication would be a way, especially when we train radiologists. And now in Thailand, we do training for them and in terms of risk communication, so that at least when they talk to the patients or the referrals, they know what to do. That's my opinion. Yeah.
Absolutely. Yeah. I have a whole lecture that I give to our radiology residents on risk communication. When I talk about radiation biology, I follow it up with that lecture. And it's so interesting, right? The perception of risk. What is low risk to you and me because we are in the field, we are professionals, medical physicists, is very different to a college student versus a grandma versus maybe a radiologist. I mean, they've done surveys of radiologists and you get numbers all over the place when you think that they should know being in the profession, right? So it's a perception of risk and how you communicate that to the patient that is so important in our field. We don't want to cause anxiety. It's really more of reassurance for the parent. And again, Sam, who probably talks to more parents than I do since he's a pediatric hospital, it's really, they just want reassurance that everything will be fine, that the one CT the child is getting is not a problem. It's not going to cause cancer in their life. And it's psychology, really, that we practice without being trained for it.
That's true. So if you want to talk, I mean, for the fetus thing, in terms of number, I mean, you said like a one CT scan should be okay, right?
More
And
than one.
more than one. So what is the number that we should
Yeah,
talk to the
so-
talk to them? Or like,
Absolutely. So, so the the recommendation from, I believe it is NCRP or ICRP, is 150 milligray, below which you do not need to take any action for fetal dose. And one CT, if we go with that conservative number of 25 milligray, we could do 6 CTs in the pelvic area. Not that anyone would do that, but you could go up as high and still say it's okay, because the risk just from natural is so different. I'll give you a quick example. There was an interview of a woman who was complaining about the construction on the road and how it was impacting her fetus. Okay, so this is a newspaper article and an interview where she's getting interviewed. And then they key down on the fact that she's smoking while she's giving the interview. So the risk, her perception that the construction is affecting her fetus, but that she's smoking has a lot more risk and alcohol than on the fetus than the CT. So in practice, in clinical practice, the benefit, if there's a benefit to a pregnant patient, go for it. The risk is going to be much lower than the benefit to the patient. I don't think anyone would get more than one CT while they're pregnant, but depends on the case. If they're really complicated, they're really sick, do 4 CTs. It's fine. The fetus will be fine.
I mean one scan, right? Like a one phase.
Yeah, what I mean is 4 CTs. So if they came today, they got a CT today, pelvis. Yeah.
One phase.
Yeah, an abdomen pelvis would be one phase. It would be about 25 according to that reference. Now, if you did a 3 or 4 phase liver, that's a little bit more that you have to worry about. But typically in my experience, but you know more as a radiologist, it's typically a routine abdomen pelvis CT that they do for pregnant patients. And even then you can try and restrict the length. You can try and reduce your MAS a little bit, the modulation, increase your noise index. You can do things like that if you know in advance it's a pregnant patient.
So which means we need to get the consent in that case.
Absolutely. You have to get consent. I think all pregnant patients, they get consent, whether it's CT or radiography or fluoro or anything, because of the additional, there's a fetus involved. So they do have to give. But what would you do with the patient who comes unconscious in the trauma? You have to, if there's no one there, you have to make the judgment as a radiologist what's good for that patient. And that means you need to know the dose and have a feel on how to talk to the patients about it.
Okay, that's good. Thank you so much for clarifications. Any more questions from the audience here? อาจารย์มีไหมคะ ไม่รู้มาก่อนใช่ไหมคะ So the question is, if the patients come to the hospital and get the CT scan or any kind of X-ray without knowing that they are pregnant.
Yes.
Okay.
So if they come and they do it without knowing they're pregnant at our hospital, what will happen sometimes is, so they go, say they found out they're pregnant, they go to their OBGYN, say they come to my hospital and go to their OBGYN, they then reach out to radiology and say, hey, my patient was in radiology 2 weeks ago, did not know she was pregnant, she's pregnant now. That's when it comes to me, and we actually do a full dose calculation. I have a 4-page report that talks about all the risks, just so that I'm informing the OBGYN. I'm giving her all the information to make an informed decision to advise her patient. Now, anything we do in diagnostic radiology does not cause dose high enough to the fetus to warrant an abortion. And I make that very, very clear to whoever I'm teaching, that nothing we do in radiology should warrant an abortion. I know, again, of another case, of a person who was a lady who was pregnant. This was in India, actually, and she was riding a bike and she fell, and she had to get extremity x-rays, so legs, and she was so terrified that she got an abortion. So the point we're trying to make is, the education we want to do is, we do not want to scare the patient so much that they make a wrong decision based on x-rays or CT alone. There might be other lifestyle factors that might impact their decision, but radiology itself, CTs, x-rays, should not, warrant that the patient get an abortion.
How often do you get to the medical legal issue or the lawsuit about this thing?
God, I hope I never do. But I have never been asked to come and testify or anything like that. So I feel my job as a professional is to give the information to the physician, and then they're the ones talking to the patient based on the information I gave, right? So I put things like, there's a table I show about, and Sam's familiar with that table too. What is the probability of birthing healthy children with zero radiation versus, say, I think it's 100 milligray to the fetus, and it shows like it's 98, 99%. Things like that. And then I also show a table in my report, non-radiation risk versus radiation risk to the fetus. So again, smoking, drinking, all of them, high risk occupations have a much higher risk than radiation does. So all of that is great information for you, the radiologist or the OBGYN, and then they have to communicate that to their patient. I have never been called in any, because it would be impossible for the patient or their counsel to prove that whatever is wrong with the child is due to the radiation, because the natural risks are so high that it would be impossible to do that.
I think that is one thing that we are concerning for here as a radiologist and also the technologists, because I believe that Napapong got a lot of curbside consultation about the fetus dose. That's why we need like the formal report and things because of the lawsuit and stuff, right?
I think it's not the matter about the lawsuit, but the point is they need documentation from us. Just to, I don't talk directly to the referrals if I don't have to, but normally the radiologist would ask me to do calculation and I give the similar report at what you do. The maximum dose that I saw when I did calculation was from 3 phases. Abdomen was like 75 milligray.
Really?
Yeah, and that's the maximum I have seen. But normally, like plain radiography, just nothing. But the mother just too worried. So the point is now we start to train the radiologist to understand the dose, and especially Dr. Panraj is very active in this patient dose and stuff. So in there, I think in the national exam, like to pass the board, they got question about this too.
I think it's very important. I think we should be training the physicians of tomorrow with all these kind of things in medical school. They need to understand the risks of radiation in medical school, because even if you're not a radiologist, you're an OBGYN or you're an internal medicine doc, you'll have patients who are pregnant who are coming to radiology. So they need to understand those risks a little bit so that they can advise the patient appropriately.
Yeah, we actually just created, so Image Gently in USA, there's 2 societies. One's called Image Gently, the other one's called Image Wisely, and they were put together to help educate people about radiation. Image Gently is specific for kids, and we just created a module that was geared towards general practitioners, pediatricians, non-radiology trained physicians that the medical students have to take as part of their curriculum. It's a 1-hour process and it talks all about risk and radiation dose. And so I think it's important for us, because we talk to technologists, radiologists, physicists, we talk in this inner circle, and it's important for us all to be on the same page. But general practitioners are the ones that are ordering the studies, usually in consult with a radiologist. And so there are a lot of resources online for people. I mean, this is something that we put together that even like the Thai people could find online and maybe figure out a way to, translate and do all that for themselves. But the point here is I think it's very important, as what's been said, to make sure we educate about radiation risk outside of radiology.
Very true.
Well, we take a break. It's for Thailand, the Royal College of Radiologists already published the document last year about patient dose from pregnant women. So how to manage, it's in Thai language, so these people can get access, because normally when the radiologists or technologists in the hospital, they want to deal with the clinician or referrals, they need a document. And in that case, most of the time they need a Thai document, like from the Royal College or for the government agency. And we have it already.
Makes sense.
Sounds good. Thank you so much, everyone. So we're gonna have maybe 30 minutes break or กี่นาทีคะ 15. We're gonna have like a 15-minute break. And we're gonna come back and discuss more in detail on this 2 more topics. Yep. So 15 minutes break. Come back at 15:15. last session for today that we are going to talk about the standardized CT protocol and DIR data collection. So welcome, Sam.
All right.
Yes.
Thank you. So now we're just going to start getting into more specific, and the topic of this one is to go over protocol standardization. It's actually probably one of the most important parts of setting up a dose monitoring system at your local hospital to have it communicate with the overall dose registry system on a national level. So there is a publication that is free for anyone to download. It comes from the Journal of Applied Clinical Medical Physics. It actually gives steps. It's geared towards the audience of medical physicists, but it is perfectly readable for anyone, technologists, radiologists, etc. And they do talk about fluoroscopy because we in the US have just started, we've been collecting for CT for many years, and now we're expanding to different modalities. But the topics, even though they talk about fluoroscopy, are very much applicable to CT. So these are the basic 5 steps that they outline in this paper. Assemble a team, complete the application process to create the dose index registry. Excuse me. Tanya made me eat spicy food over the break. Set up a server and server login, validate your data, and then map procedure exam names. All right, so each hospital participating in a dose registry system, so of course here in Thailand, will want to identify someone to fill the following roles. So this paper defines a physician champion. Now, I know Panrutai has been kind of physician champion here in Thailand, has really been driving this forward. So she's been doing that on a national level, but specifically we need someone kind of at every hospital. They're the ones that will help coordinate and direct the implementation process. So to start the process, once the data goes out, and then once the data comes back, we need a radiologist or a physician to champion that process. And then, of course, technologists. They're the ones that help manage the day-to-day operation of the system, the mapping of the site-specific protocols to the general protocols that would be used for the dose registry. And we will I'll go through a couple examples. Radlex, of course, is what you guys use here in Thailand. We use that quite a bit also in the US. We'll give some more specific examples at the end of this talk. All right. And then, that's out of order. Sorry. The other one, of course, is medical physicists. I'm one of those. And we kind of work to help bridge the difference between radiologists and technologists. We're there as key players with the kind of the in-depth understanding of the technology. Depending on how many technologists or how many physicists that are available at any one time, the roles will probably be shared pretty equally. And then, of course, we need, everything's out of order, information technologists and server administrators. So you actually need IT support. This is a very technologically complex process to marry the dose monitoring system and have all of the different modalities feed into that, then have the dose monitoring system feed into a local server. That local server has to feed into a national server. Then that has to go sideways and for a bunch of analysis and processing, and then you get the report back. And so there's many steps in there for IT specialists. When it comes to being kind of a server administrator at the local level, at the local hospital, this person could be really the IT specialist if you have them, PAC specialists, who might also be a technologist or a medical physicist. So as an example, I'm the admin of our dose monitoring system server. And so I handle and I verify and make sure all the data and all that is proper. When it comes to connecting server to server, our actual IT folks handle all that. So once we've assembled our team, and then each person really has a key role, physicians, mostly radiologists, of course, technologists, physicists, and the IT folks. What we need to do is you need to come up with a process. So in the US, we have what's called the National Radiology Data Registry, or the NRDR. And under that, there are subspecialty registries. So CT is one of those. We are doing other modalities, and we're doing other things such as, for example, IV extravasation, colonography. So there's lots of different ways to do this. But they have the major group, NRDR, and the process is actually relatively formal. And so if you want to be a part of this process, you actually have to create a form, not create a form, but you have to register, and you have to go online, you have to fill in a lot of information. There's fees. We actually have to pay into the process in the US. So obviously that model may not be as applicable to Thailand, but the idea here I want to demonstrate on this is it's very helpful that as this becomes more formal, that the OAP actually creates maybe like a website, and so a central location where people can go in to do the registry, even if it doesn't cost money, but it has a formal way to place documents, registration, all of that information here. You just need a central repository so everyone knows where to go to get information, and then they can get that information. And it's very helpful for us here in the USA because there are thousands and thousands of sites that participate in it. And so they can keep the information they can keep the information updated on the website. And then everyone in the US, of course, knows where to find that information. So in general, how does that apply, I guess, to the Thai? How would that apply to Thailand? You just need to come up with a very formal process. That's something that can be adhered to from the smallest to the largest hospital. All right, next thing is, as I mentioned, there's that technical component of setting up the servers. So obviously, as Nepapong mentioned, that the OAP is kind of hosting that, and they're expanding. That's neat. That's just really neat that they're going to try to move towards a 2 million study expansion and bring on 8 more sites. And so this is actually a very active and developing idea within the framework of the National Dose Registry here in Thailand. In the way the ACR does this, though, is there can be hospitals that will each apply individually to get into it, but there can also be larger organizations. They call them corporate accounts. But in the US, for example, there could be multiple hospitals under one umbrella, one main entity. And so the system is set up so that even if there's, say, 10 hospitals in one entity, there'd be only one server. And so it depends on how it's configured here. And of course, I don't fully understand that in Thailand. You may find that there is a group of hospitals that are in some way related. And so you would really only need one account, one server, and then all of that information to go through there. That's one server. And so just looking at the geography and how it's laid out may depend on the complexity of the process, of how many servers you have to set up, etc. All right, so validating the data. This is a real crucial step. We've got the team together, we've got the server installed, both the server locally to collect the dose monitoring, for dose monitoring, and nationally to collect the data for the dose registry. Before we send the data off, we need to take the time to make sure it's properly set up. So the first thing you can do, as kind of been discussed a moment ago, is how many protocols do you have on your scanner? And being able to define which protocols will be used for the National Dose Registry to establish DRLs. There's, Nepapong mentioned, I think here locally, there's some hospitals that have 600. Kalpana mentioned that hers had 250 plus. I know, for example, we had 250. I'll give an example of how we reduced that in a minute. But you have a lot of protocols to go through. And so it's very helpful to reduce the duplicates. There are, as I've gone through as a physicist, my protocol tree, there have been many times where I've looked at, they'll have maybe a certain various different levels of abdomen studies, but when you actually look at the acquisition techniques, they're the exact same. They're just named differently. And so you don't necessarily need 20 or 30 of the same protocol with the same technique factors. There's one example of this. If for some vendors, when you set up pediatric protocols, they use this color scheme called the Brasilo-Luton scheme. And so they set it up so there's 9 protocols for every indication. 9 abdomen, 9 chest, 9 head, etc., etc., etc. And I have long found that that is actually way too many options. And I'll show you what we do in a second. Is there a point where there's too little? Probably. If you have one protocol and you're using that to scan every part of your body, then yeah, you probably have not optimized properly. We will talk a lot more about optimization on Friday or Thursday and Friday, but you need to take the time when you're validating the data to first clean up your protocols. This is a really good opportunity to do that. Make sure you've got everything that's matched up. So for example, chest abdomen, make sure that the chest portion of this combo is the same. So if someone gets a routine chest exam or a chest abdomen, the chest component is the same. Brain without contrast usually should have identical radiation doses brain with contrast. And so you just want to make sure that your protocols are the same, because eventually you're going to map those to go up to the National Dose Registry. So why parse out protocols? So how do we parse out the protocols? So one example here is this is head. This is a plot of patient age as a function of the transverse measurement of the skull or the head. And you can see that as an adult, our heads largely don't change. After about 5 or 6 years old, our head is basically the same size. And so if you're largely imaging adults in your clinic, you probably only need one protocol to do a head exam. But if you're doing pediatric protocols and you're imaging consistently for kids under 2 years old, now you have this logarithmic relationship, and you may want to have several different protocols in this region right here so that the dose is more appropriate for the little heads and as the head continues to grow up to those couple of early years. So as an example, the way we do it at our hospital, we have 5 protocols. 4 of them basically are pediatric, and the 5th is, of course, more of kind of your teenager, young adult, and adult. But as you can see here, we've really finely parsed it down to this range because that's when the head grows the most and the patient is the youngest. Same thing can be done for the abdomen, or just at least the trunk. And once again, I'm demonstrating where you take the data, you look at your data. So in this case, now I'm looking at it as a function of weight, patient weight along the x-axis. And now I'm using that metric that Dr. Kanal just described very well, CTDI vol. And as physicists, we tend to always look at the volume CTDI more than DLP, but you could easily have plotted DLP on this side or SSDE. You would largely get the same kind of response of kind of this exponential increase. Of course, the numbers would just be shifted along the y-axis. But once again, you see trend. You can see that as we get bigger, our bodies variation can change quite rapidly, and so therefore the radiation output from the machine has to compensate for those larger bodies. Whereas down in this region, you know, young kids, toddlers, maybe even into teenage years, maybe they have the same relative size body for a while. You know, kids tend to be cylindrical. They don't have a lot of change in their anatomy. And so maybe we don't need that many protocols. Once again, as just an example, this is the way we broke ours up, 4 pediatric and 1 adult. It can be done however you want, but the main point to take away from both of these discussions is you need to look at your data in your your hospital, and you need to make a decision of how many protocols you need and to properly optimize them. So as I mentioned that a moment ago, we had about 250 or so protocols. And that's basically because we're pediatric and we have adults, and we had a lot of stuff that we had mixed together. On one of my scanners, I only have 50 protocols now. And that's because as technology has improved, several vendors, pretty much all of them now offer something like this. Not every one of them, but most of them offer the opportunity for the system itself to make a proper decision as to which which technique factors to use based on the size of the patient. So historically, or I would even say currently, most people will go in to their hospital, and they'll create 1, 2, 3, 4, 5 protocols. They'll be broken up by weight or age if it's the head, and they'll have specific KV, MA, rotation time, noise properties, all of that we typically deal with in CT. They'll be all separated and they'll be individual protocols. Well, now what we can do is we can say, well, based on the patient's size at the time of the scan, we can let the system pick from a table that you as a physicist or technologist will develop in the background, and it will then pick the right KV, the right MA, the right noise, and all that kind of stuff. And so this is why nowadays, if I sit at my scanner, I have one abdomen protocol, but it will pick the right KV and MA and all that stuff depending on the size of the patient. So these CT scanners, especially the more advanced, newer ones, are very technologically savvy. And we have largely never used all the technology on them. We've always limited them. But more and more with newer technology, which we're going to talk a little bit more at the end of the week about, the scanners have become a lot smarter. And they're always been smart, but we're starting to let them do a lot of the choice selection. So this is exciting, I think, but we'll get into that a little bit more in a couple days. So now, once you have done the cleanup in-house, you're prepared now to start sending the data. You need to make sure, first of all, that you're connecting with the national server. So make an initial validation that the data is going up, that the OAP is collecting that data, and then, I got that. Sorry, the acronym, I misspelled the acronym. But when the data comes back, you want to make sure that the data coming back is matched up properly. And a really good way to do this is if you send them 1,000 studies, when the data comes back, see that they have listed 1,000 studies. Make sure that data is not being lost in translation. Also, make sure if you're sending a specific number of head exams and a specific number of abdomen exams, that those numbers come back. So just make sure the exam descriptors are linked up and the numbers, etc. So you just want to validate data in and validate data back. All right, and then the majority of what I want to talk about today is actually how to communicate. How do we speak the same language between your hospital and the National Dose Registry? And that is all about establishing the proper nomenclature. So there's a couple of things you can do. Of course, when you set up protocols at your hospital, you should do it in a kind of standardized way. There's a lot of, the IAEA and or the ICRP and various different publications recommend doing a standardized protocol. So they recommend, for example, naming a protocol, patient category, body part, age or weight. And so you could say you're doing a pediatric head, C-spine, 6 to 12 years, or something to that effect. This is a recommendation, it's not a requirement. But as you move forward developing new protocols on your hospital and new CT scanners that come on board, if you adhere to something that's similar to this, or something that is agreed upon across maybe the national government of here in Thailand, then it makes the next steps we're about to talk through a lot simpler. So naming convention needs to be somewhat logical, and then we need to connect that naming logic to some kind of national or regional ID. So consistent naming, one of the other ways to do this, one of the biggest problems that we find when you look at the national data that's coming out of kind of the ACR-DIR is, for example, if you have a thorax CT angiogram and a chest CTA, well, those are the same protocols, but they're just named differently at the local hospital. And so making sure that they're both being mapped properly. Yeah, that's exactly what I just said. All right, so how do we do this? How do we name this? So there are probably 4 different ways that we can do that here in the US. And I think there's a couple of ways that are equivalent here in Thailand. So in the US, we have CPT codes, or the current procedural terminology. It's based on billing. And I know Nepapong demonstrated the same thing for you guys. And that's why you guys have 14 instead of 10, because you added those 4 extra based on your billing codes. So billing codes, obviously, are how the hospital communicates nationally for the funding. And so it's one way to just make sure that the terminology, the naming of the procedure is the same. That's one approach. Second approach is called Systemized Nomenclature of Medicine Clinical Terms, or SNOMED CT. This is a international approach. It's actually used to unify clinical terms, not just for radiology, but for everything across the medical climate. It's used, as I mentioned, internationally in a lot of countries, but it does cost money to use. So if you were interested in using that, obviously I know here in Thailand you guys are using Radlex, but for those other people outside of Thailand listening in, if you were interested, this is an option. It offers the same things that we're going to talk about now when we talk about Radlex. So I already mentioned that LOINC or Loinic and Radlex kind of married their two playbooks together. And so now it's just one on the website. And they established it so that there's a standard system for naming based on modality and body part. And the best part is it's free. And then there's the ACR Common. So if you were, so in the US, of course, as you're a part of the ACR, this is something that is basically like the Radlex system. It marries, it gives a naming convention for modality and body parts, and it's for across all modalities. And there's a couple of other things that you get, like the ACR appropriateness criteria, if you buy into this process. It does cost money. We're going to talk a little bit more about ACR and maybe even the Thai government or hospitals being a part of the ACR as a way to benchmark your data with, say, US data. So we're going to talk a little bit more about that in some different talks. So what do you get when you go for the Radlex playbook? Well, you go to the website and you'll have this type of screen that'll come up, and you'll be able to kind of play with it in a variety of different ways. So what I wanted to do was flip over and show you. So you can simply just go to Google, type in Radlex, and it would be one of the very first things that come up in the search. Is you go to Radlex radiology. See here, all I did is simple Google. It's the first thing that's going to come up. The nice thing about this website is there's a lot of information here. So you could go straight to the playbook, and we'll do that in a second. But if you want to look at different templates, if you want to look at different information, educational information, there's just everything here. You can go to the radlex.org, and that gives you more of a detailed explanation of how they systematized the ontology that came up with the naming schemes. So that's if you're just really interested in that. But as I mentioned, if you wanted just to go here straight to the playbook, this is what I had on my slide just a minute ago. Obviously it's updated here, and the best part about this is you can go in and you can systemize how you want to change things, and you can do it very simply. So if you have, for example, the task of trying to identify, we need an abdomen with and an abdomen without. So how do we know what the naming scheme is going to be? So you have your protocol on your CT scanner at your hospital, however it's named. Say it's an abdomen with. And then what you can do is you can come over here to the Radlex. You can pick the modality that you want. In this case, we're interested in CT. You could be, if you're at a pediatric hospital, or if you're trying to map pediatric protocols, of course you can select that. If you just leave this field unselected, you're going to get the adult world. And then you could you can drill down a little bit more and get a little more specific as to what you want. In this case, we were going to look for abdomen, but you can of course look through all of these different body parts. Now, you do not need to fill in all of this. There's a lot of modifiers here. Laterality, that doesn't really apply, of course, in CT. If we were doing this for DR, that would probably be something you'd want to use. But once you get it to just a couple of basic filters, if you hit, there we go. Nope. Yep, there we go. Yep, CT and abdomen. Okay. So now it's going to come up with this list of CT, obviously, and anything that had to do with abdomen. So it's helping you reduce that list from several hundred to just a couple. Now we were looking for CT abdomen with, or there's a CT abdomen with, without, and that was without, WO, without, and then CT abdomen with. So here's 3 options right there. And what we're going to do is you're going to pick, if you're trying to link the CT with, then you would come over here and there's this RPID 5. And that helps you now associate your protocol, whatever it's named at your hospital, with a quote unquote CT abdomen with, and at the OAP level, at the National Dose Registry, they're going to link it all based on this RPID value. So it's a very simple tool. You can go in, that's how you find your RPIDs and your standard naming conventions. I forgot to point out here the long description here. This is just obviously a short description. This will always over here tell you a little bit more on the right hand side of your screen, a little bit more in-depth detail of what that protocol is really meaning to cover. So CT abdomen pelvis without IV contrast might be only called CT abdomen pelvis without, but it just helps you just to narrow it down a little bit more. So that's if you wanted to go online and do that. It's okay to do that online. I would say if you have just a couple of protocols you're working with, but if you really want to do a very large update and you've got lots and lots of protocols to do, another thing you can do is you can actually download the playbook. So on the right hand side, so I show you this on my slides because I wrote it all out because all the participants will have access to the slides, but I'm trying to show you this a little bit more interactively online. But you can come over here onto the right hand side and you click on download, you agree, and then you have these options. And so this one right here, the core playbook, is probably the best place to start. And you can click here. There are other versions of things that you can download if you want. Now it's coming down. And there it is. So I'm just going to launch it. So there's the playbook. This is exactly what we were dealing with online. Here you can see there's, let's see, just shy of 1,000 entries. So how do you want to sort through that? Is, in my personal opinion, you come over here, you add a filter to that top column, top row, and now what you have are a lot of different options to sort through things here. So we have the short names, long names, we have the modalities. So here you can see by clicking, of course, for those of you familiar with filters, you just click on that little down button and that'll list everything that's in this column. Obviously we want to just do CT, so I'm going to only select CT. And that's going to now reduce my records. So now I went from just shy of 1,000, now there's only 103. To be more specific, so we got CT here, but now what if we want to do abdomen? So now you have all kinds of different options. There we go, body region right there. So now if I wanted to do abdomen, I could do any one of these body regions. I just selected abdomen, and there you go. Now, this list is the same thing that you saw down here. So this is kind of one way if you want to just do it offline, you're using your computer, you can actually link if you want, if you're pretty savvy with Excel, you can have it do auto lookups. But the point here is what we're trying to do is we're trying to find these RPID values to associate the name of your protocol, whatever it is at your hospital, with one of these standard names, be it short or long name. All right, so you can do it online, you can download it, do it offline. Either way, you come to that same answer. You filter it by modality, body part. We just talked about this, so I'll kind of click through it quickly. The playbook is constantly changing, so if you do download it, you should probably download it periodically and don't just stay with it forever. That's probably the one negative of downloading it. You can sign up for email notifications, then you'll always know when it changes. All right, so that's the Radlex. That's probably the easiest one, probably for everyone to use. It's free, as I just showed you right now. Anyone can log into it at any place in the world. There are some benefits if you were to become a member of the ACR It's actually not that expensive, and it gives you full access to associate your data with their data as a benchmark. And the reason I wanted to point this out is because they also have a name mapping tool. So I'm going to just demonstrate how they do it. There we go. And you'll see that it's actually pretty similar to the Radlex. Ultimately, the end result will still give you an RPID value. So once again, it's going to have a list. The one nice thing about the ACR is once you've done it, you can actually connect it and upload all of your protocols. And so now it's going to list all of your protocols here. The system will then, using some technology, basically go through and select the right tag ID. And so it's getting smarter. They're about to roll out some new AI technology that will be even better than the just simple naming convention association. And the AI technology is meant to also help you just take that middle person out of it. And we're hoping to get away from the idea of you picking the name of the protocol and associating that with the protocol at the national level. So the ACR does have that opportunity. You can see here that occasionally, once you've uploaded it, there will be some here that'll be marked not tagged. And so even though it's auto tagging it, some won't be tagged and you'll have to physically yourself go in there and mark it. Or sometimes you will click on it and you will untag it and you want to do it manually. And that's just because sometimes the naming convention, whatever you had at your hospital, just might be so unique to your hospital that this ACR software couldn't figure out an appropriate correlation. But ultimately, as I mentioned, no matter what, the goal is to get an RPID. All right, and then the ACR has a few other features that Radlex doesn't have. So for example, you upload all your protocols to it. This will list all the protocols that haven't been properly tagged. And so you don't actually have to look through your entire protocol tree. You can just click on this little hyperlink right here, and it will just show you the 11 that you need to work on. So you might have 250, you might have 600 protocols, but you only need to focus on 11. So that's actually kind of a nice thing. Similarly, as Radlex, you can actually export this and you can do it all manually. Or if you want, you can export it, you can associate all the RIPDs yourself, and then you can upload it, and then it's all associated online. So if you are more of an Excel person, you can just do everything in Excel and then just upload it and you're all okay. If you are at all interested in the ACR stuff, and I should just preface that saying I do not work for the ACR. I have no monetary interest in the ACR. You do not even have to do it, but it's just a tool that is out there. It's one of the 4, I think, tools that you really have an option to use. But there is, if you just follow this link, there's a video that shows you how to do this in real time. So in conclusion, the way that people have done this in publications and the IAEA and everyone, they recommend kind of 5 major components to protocol standardization: assemble a team, create some kind of application process so that everyone knows how to register for the National Dose Registry, set up a server. Obviously, we go through that. We talked about validating your data, starting by cleaning up your data first at your local hospital, naming it properly just from the beginning, and then number 5, mapping the procedure names. This, the mapping exam names is only one step of the 5, but I would argue it's probably the most important and the most involved. It's definitely difficult, especially just depending on the complexity of the naming structure you have at one hospital. And if you're someone that covers 5 hospitals and they each have 5 or 6 CT scanners, I don't know, but it quickly becomes a very, very big project. So it's good to have a team to help you. So at that, if there's any questions, we can talk about that. We can even go through some examples if you have questions specifically about how to map some naming. Okay. Yeah. I mean, this is something that we've talked about for the last 3 or 4 years. So I know here in Thailand, you guys are very well established. All right.
I have one thing. So like over the lunchtime, Panluthai and I talked together about the process that you said the data that we have from the hospital level go to the server and then server go to the OAP server, right? And the issue that we have right now, because even we want to have more hospital to join the system, but it's gonna be maybe like some cost or money that they need to pay to transfer those like a data. So how do you guys do it at the ACR level on those things? You have like someone to pay those things, or
Yeah. So the ACR, so we pay, as I mentioned, we pay to be a part of this. My hospital pays a couple hundred. It depends on the number of physicians, radiologists you have, the number of scanners. It's not meant to be horribly expensive. You know, it's a couple $100, maybe a couple thousand at most. And so we pay to get into that process. And what are the benefits that come from that? Well, obviously there are the benefits of getting the data back. It's all processed. It comes in a nice report. And so they help us really understand, oh, here's some problem areas. Maybe you should work on that. So that's kind of the number one benefit of being a part of it. But the other benefits to it are we have accrediting bodies. The ACR is an accrediting body in the US. So that helps also because the hospitals need to be accredited. It helps with reimbursement. There's a lot of things that might be unique to the US. I don't know exactly how that would all work here with the universal health system, but that gives the incentive for the hospitals to be a part of ACR. I would argue most are, but probably not all hospitals in the US are a part of the ACR, but a very large part of them are. And so that small little fee that they do charge helps pay for the staffing, the servers, and everything, because that is an overhead that can be very expensive. So in the U.S., the government has a certain. We're not universal healthcare, but we have what's called Medicaid, Medicare, and so to be a part of the reimbursement from the government, you do have to be accredited, and so that is one benefit. For those private hospitals out there that don't care about Medicaid, the government funding source, then they don't necessarily have to be a part of it.
I think at the end we have quite similar, like we have the government scheme and then the social security and then universal coverage. But at the moment we have accreditation, but it's for radiation dose is not gonna be the first priority at the moment. More like they will look at the quality of the staff and also like the how well you perform in terms of providing the care of the patient. But what we try to push in the near future, after everything else is established, then we will start to impose the dosimetry part, and that's the way that we are looking for. So at the moment, it's quite a big challenge for us because this DIR is volunteer, and then if the hospital want to join, they may have to pay from their own expense in terms of in case the system is not compatible with the data clearing system, then they have to pay. But at least they need to set up the firewall or something so that they can be compatible with the system, and that costs some money. So I kind of talk to the vendor because some vendor they want to expand the market. So like for here, the government hospital may not have the money to buy. The deal is like one vendor, if you renew the contract, the maintenance contract for CT for 2 years, then you get the free dose management system from that company. So maybe that's the way.
Yeah.
And then I talk to them if they want to join this. I ask them they may have to allocate a small amount of money to get the system ready to be able to connect to the main server, because the main server is Radiomatrix. So if you use like DoseWatch or something else, there might be some issues.
Yeah.
Then you may have to have some investment on this. It won't be a huge money, but the hospital, of course, they may not have the money to pay.
just have a comment on that. So, you said that some hospitals don't have the money. So dose monitoring systems are very expensive. In the US, you could spend up to $100,000 on a dose monitoring system. That's a lot of money. One solution could be that if your hospital cannot afford to buy a dose monitoring system, you could participate in the American College of Radiology dose index registry program, which is, as Sam said, depending on how many hospitals you have or how many radiologists, it's anywhere between $200-300. We pay $2,000, but that's because we have 4 hospitals. That is a much cheaper solution than buying a dose monitoring system. So, say Hospital A in Thailand, is participating in ACR, dose index registry. So they would get their reports, and you have your own dose index registry in case they don't, they can't participate, but they can compare that system to what you have in Thailand and still be able to participate in some way to see if their doses are okay. You see what I'm saying?
What is some hospital been trying to involve with the ACR, but the ACR does not do business outside the US for some reason. No, I like for like MRI accreditation or CT accreditation and things.
Accreditation, I don't know, but
Yeah. Okay. So that means if you pay that amount of money, then you can. Okay.
compared to buying a dose monitoring system, which is
Okay.
thousands and thousands of dollars.
But the data they will get is only the hospital compared to the US data.
Correct, but they will still get something
Mm-hmm.
that they see how they're doing compared to the US. But then you also have your Thai system. So there could be, then you could compare their report to what you have.
Okay.
It's a little indirect way of doing it, but it still shows them something. how
Okay.
they're doing, right? Then nothing.
Yeah.
Mm.
The other thing I would recommend is, Radimetrics is the main server, but there's also a lot of different other, there's 18, 20, 21 different versions of dose monitoring, and some of them are free.
Mm-hmm.
And so you could probably try downloading a free one, connect it to one CT scanner, have it send some protocols over, and then have that try to connect with Radimetrics and see if there are some free solutions or some cheaper solutions out there that are compatible with Radimetrics. I know we personally have Radimetrics, we have PEMNet, and we have Gerbay's Dose and Care. We have 3 dose measuring, and that there's a long history of why that's the case. But I can tell you that the Gerbay one and the Radimetrics ones do connect because we're moving studies back and forth.
Mm-hmm. It's a good idea in case we have a good physicist on site.
That is the caveat to that. If
Yeah.
it's just a random hospital,
but we don't.
It's hard to do that.
Yeah. So at the moment, we try to do best based on the solution that we can offer in this country. So it looks like it's gonna be like what I said. Like now we have 50 sites. At the moment, we will try to persuade them to connect their data to our system. And then with additional sites, as the vendors, they all want to market this. And I think later, if the Joint Commission International enforce the dose management system,
Yep.
this thing will happen for sure.
Yep.
I think I hope the next round of JCI they will start
That
because
was-
now they lack 2 rounds already.
That was a very big motivator within the U.S. population. Most hospitals, probably 10 years ago, I would say maybe half had dose monitoring software, and then the Joint Commission came out and said you must monitor fluoro, you must monitor. Everyone had always been doing CT, but they added fluoro and all these other things, and then overnight everyone had dose
Yeah.
monitoring software.
That's the thing. We need to be forced to do things here.
State regs. Yeah.
Just the small size, like CT only. If you want to do CT only, it's less than $30,000.
You can monitor mammo, you can monitor nuclear medicine, you can monitor radiography, and very important. And both Sam and I are going to show you, and I think on Thursday, how we use our dose monitoring systems for how do we use it? Another big factor is interventional fluoroscopy radiology procedures and monitoring that skin dose. Amazing to have dose monitoring system for that. So you could buy it for CT as a starting point, but at some point you're going to have to extend it to everyone, and that's pretty expensive. Yeah.
Most of I think 100% of the DMS that we have now are full function. We do everything, but the vendors, sometimes they give the choice to the customers if they want just to comply with the accreditation or whatever, they can customize the price.
Okay.
I just want to hear something about like the history on how you help the ACR set up on this thing on your pathway and how difficult it is. Like how you help the ACR set up with the DRL and everything. I mean, on your perspective, like how did you help them? Oh, okay, that's good. Yeah, I just want to hear like from the starting point that you do that things with the ACR and how can we compare with the step that we do here and any. Okay. Okay. Yeah, that's good. Yes, not today. Yes, I do agree. So thank you so much, everyone. So right now we still have 74 audience online, which is a good number. So we will see you guys again tomorrow. We will send you an evaluation link, maybe like at the end, right? Are you going to send it like every day or จะส่งลิงก์ทุกวันไหมคะหรือว่าจะส่งที่สิ้นอาทิตย์แต่มันรวม so we will send the evaluation link by the end of the week. So if you complete the link, the evaluations, you will get the CME credit for the whole course. And tomorrow, I think we are planning to take a photo. So like the photo for the people on site and the photo for the people online during the morning break. So be prepared. So we're gonna open. If you can open your video on the online, we can take a photo like your screenshot online, and for the people on site too. So thank you so much, everyone, and see you tomorrow. Bye bye. ฝนตกนะคะ ฝนตกค่ะ รุนแรงอยู่นะคะ See you tomorrow. Bye bye. Thank you so much.